Good evening to all. This is Ranjit Sahu, Head of Marketing with Walter Busnell. Welcome you all to this lovely Saturday evening. We have an education feast today in Saturday evening, like amongst Public Awareness Committee and Infertility Committee jointly present the Infertility Awareness Program. We have two very relevant topics, that is role of hysteroscopy in infertility, which will be talked by Dr. Kalyan, and fertility enhancing laparoscopic surgery by Dr. Jay Mehta. And we have a lovely panel discussion on optimizing outcome of fertility treatment. With this, I hand over the session to Sachin to take it forward. Sachin, over to you.
Thank you, sir. So, good evening, all esteemed faculties. So, ma'am, can you share that video first? Monica, ma'am. Yes, ma'am.
Which video are you talking about? Inauguration, no?
Yes, ma'am.
Yeah, just introduce Dr. Pratibha, ma'am. She will do the inauguration.
Okay, ma'am.
You start the slide share. In that, there will be the PPT. So we can start with that. Yeah.
Yes, ma'am. So, good evening. I'm here to introduce Dr. Pratibha Baldava, ma'am. And she has a gold medalist at DFP, Fellow of American College of Obstetric and Gynecology, when obstetrician, gynecologist, and infertility consultant at SS Baldava Hospital at Solapur. She has treasurer SOGS 2017-18, when honorary secretary SOGS Solapur Obstetric Gynec Society in the year of 2018-19, executive member of Solapur Obstetric Gynec Society 2011 to 2023. She has published 12 national papers in Indian Health Journal, J. Repro Science, Indian Obstetric and Gynecology Research.
Thank you so much, Sachin. That is okay. A very good evening to one and all. I, Dr. Pratibha Baldava from Solapur, welcome all of you to this infertility awareness program, which is organized by the AMOGS Public Awareness Committee and the Infertility Committee. I would first invite all of you for the inauguration of this webinar. Sachin, can we have the video of the inauguration?
Yes, ma'am.
Yeah, you can enlarge the slide and you can save slideshow from this slide.
Make it slideshow, please.
Yeah, make it slideshow. Yeah. Okay, welcome all the reputed, esteemed members of AMOGS. I welcome Dr. Kalyan Baramde, sir, who is the chairperson of the Infertility AMOGS Committee, to take the session forward.
Thank you, Dr. Monica.
Can I have Dr. Kalyan Baramde, sir, CV, please?
Yeah,
I
yes,
just
okay,
want to
no
introduce
issues.
Kalyan, sir, for a minute.
It's okay, ma'am.
How are you, sir?
I'm fine. Thank you, Dr. Pratibha Baldava, and thank you, Dr. Monica Umbardand and Dr. Kiran Kurtakoti, Dr. Sudha Tandon, who have joined for this webinar. I welcome all delegates for this infertility webinar, which is a brainchild of Public Awareness Committee of AMOGS and Infertility Committee. I welcome all the delegates, and it's going to be a feast because we are going to talk about the fertility enhancing hysteroscopy, fertility enhancing laparoscopy, and then a panel discussion about the same. So I welcome all the delegates, and we should start the webinar now. Thank you so much.
Thank you, sir, for associating with the Public Awareness Committee of MOGS. It is always a pleasure to have you as a faculty, and your guidance is really, really essential, sir, at every step. Thank you so much, sir. And Pardeshi sir has sent his blessings because he is traveling, sir, to outside India. So he's sent his best wishes for this webinar. And Prakash sir will join in another 5 minutes, sir. So you can introduce Prakash sir after he joins.
We are very thankful even to Monica, who is the chairperson of Public Awareness Committee, and she has always been taking efforts to conduct such webinars and to bring all of them together and create awareness about various topics. Thank you so much, Monica. Can I invite the chairpersons now so that we can start the first session?
Yeah, sure.
Or, should we wait
sure.
for Prakash Trivedi?
If sir comes, we can take his blessings in between.
Yes, okay. So now I introduce the chairpersons for today. The chairpersons for today are none other than the President of Solapur OBGY Society, Dr. Vivek Virkar, sir.
Sachin,
Hello.
please put Vivek sir's slide.
Yeah. Dr. Vivek Virkar, sir, is the current president of Solapur OBGY Society. He has done his MD DGO and presented various papers at state and national conferences. He has worked as lecturer at OBGY department of BA Medical College and is a director of Virkar Maternity Hospital. He has been the honorary treasurer at RCOG conference and honorary secretary of 2000, 2008 and 9. He was a treasurer in 13-14 at SOGS and he has won the best paper prize at AICOG and AMOGS during post-graduation. I welcome you, sir.
Thank you.
The other chairperson for today is none other than the VP, the Vice President of AMOGS, Dr. Kiran Kurtukoti, sir.
Sachin, please change the slide.
Can I have the slide? Yeah. Dr. Kiran Kurtukoti, sir, is a Vice President of AMOGS. He has been the ex-chairperson of MTP Committee FOXY 2009-2011, ex-chairperson MTP Committee AMOGS, and he has done a lot of work for the for welfare of women regarding abortion. He's the director of Shashwat Multi-Speciality Hospital.
Pratibha, that's fine. Dr. Pratibha, that's fine. That's fine.
Thank you so much for joining us, sir. Thank you so much. The other chairperson for today is none other than Dr. Sudha Tandon, whom we know very dearly and very close to us. Can I have a slide, please? Dr. Sudha Tandon?
Yes, ma'am.
Yeah. Dr. Sudha Tandon is the Joint Secretary of IAG 2023-24. She is the MOGS and ISAR committee member and organizing chairperson of MOGS IAG Indo-ART conference in 2018 Mumbai. She is the FOXY chairperson for Sexual Medicine Committee 2017-2018, a faculty at IMAS, and she's felicitated on Teachers Day by MOGS 2021, AICOG Jan 2002 winner. We are very pleased to have you, ma'am.
Thank you. Please go ahead. Yeah.
I hand over the mic to the chairpersons to conduct the first session. The first session is a talk by Dr. Kalyan Baramde, sir, on fertility enhancing hysteroscopy.
I request Dr. Vivek sir to please introduce Kalyan sir. Sachin, can you answer a slide, please? And
Vivek Virkar, sir, is there?
Good evening, everyone. At the outset, I would like to thank office bearers of AMOGS PSC and Infertility Committee for giving me this opportunity to chair this session. Wonderful session. As you know all, the hysteroscopy is the third eye of gynecologists, as it illuminates the darkness of uterine cavity, and it is a wonderful technology that least invasive form of treatment. So the today's topic for discussion is role of hysteroscopy in infertility. And the speaker is Dr. Kalyan Baramde sir. Dr. Kalyan Baramde sir, he is a consultant gynecologist and infertility specialist. He is a director of Baramde Hospital, Latur. He is chairperson of Infertility Committee AMOGS 2022-24. He is a president of IMA 22-23, executive member of MSR. He is secretary of IAG. He was chairperson of Public Awareness Committee FOXY and convener Mission Save Uterus FOXY. He was organizing chairperson AMOGS 2022 at Aurangabad, and he was a past president of Latur OBGY Society. So I
Thank you, Vivek sir. Yes, sir. Thank you, Vivek sir, for such a nice introduction. Can I share my slide, please, Sachin?
Yes, sir.
Can you stop sharing? Yeah. At the outset, I'd like to thank Dr. Monica Umbardhan for giving me this opportunity. I thank all my esteemed chairperson like Dr. Kiran sir, Dr. Sudha ma'am, and Dr. Vivek sir. And I'm going to talk here on a topic which is very close to our heart, that is hysteroscopy. How we can enhance fertility by doing a hysteroscopy. Uterine abnormalities like polyps, submucous leiomyoma, intrauterine adhesions, chronic endometritis, and congenital anomalies have been reported in 21 to 47% of the patients who are undergoing IVF cycles. Endometrial polyp accounts for 32% among subfertile women, implantation failure in 16%, and associated with endometriosis in 46% of the cases. Uterine septum, though prevalence is low, the true prevalence is difficult to ascertain as many are asymptomatic. Infertility in 21%, incidence of early miscarriage in 41%, and late abortion and premature deliveries in 12% of the cases. If they conceive, they have malpresentation, fetal growth restriction, placental abruption, or perinatal mortality because of the premature delivery. The Asherman syndrome, which is prevalence of Asherman in infertile population, is around 4 to 6%, infertility in 45 to 50% patients, early pregnancy loss in 25 to 40% of the cases, and preterm delivery in 23 to 30% of the cases who conceive, and placenta accreta in 13% of the pregnant patients. Also, ectopic pregnancy is there in 12% of the cases. So our hysteroscopy is a tool which is going to help us for doing the successful surgery for septum, polyps, removing foreign bodies, submucous myoma, and even hysteroscopic corneal cannulation. The variety of the benign intrauterine pathologies are common. Out of those, the two most common are polyp and submucous fibroid. As you can see here, this is endometrial polyp, which is diagnosed on ultrasound. The TVS has sensitivity of 19 to 96% and specificity of 53 to 100% of the patient. Color flow Doppler is going to show you whether there is a feeding vessel which is there or not. The AGL practice report guideline says for diagnosis of endometrial polyp, TVS provides reliable information for the detection of endometrial polyps and should be investigation of choice wherever it is available. The addition of color Doppler increases the capacity of TVS to diagnose endometrial polyp, that is level B evidence, and adding intrauterine contrast to sonography without 3D imaging improves the diagnostic capacity for endometrial polyp. The blind dilatation and curettage or biopsy should not be used for diagnosis or removal of endometrial polyps. So we recommend expectant management or surgery for those patients. So whenever a patient of endometrial polyp come, if it is an infertility, the patient with polyp surgical removal is recommended to allow natural conception or assisted reproductive technology a greater opportunity to be successful. That is level A evidence. And lack of association between size of polyp and fertility outcome goes against a mechanical effect. So glycodyline inhibit sperm oocyte binding and NK cell activity in ovulatory human endometrium. Glycogen levels are very low between 6 days before and 5 days after ovulation, that is peri-ovulatory period. This facilitates fertilization and then the level increase significantly 6 days after ovulation to suppress NK cell activity. So it is speculated that fertilization and endometrial receptivity may be altered by increased glycodyline production in the uterine cavity of the patients with leiomyoma and polyps. Also, presence of polyps may alter HOXA10 and HOXA11 gene expression, which is established molecular marker of endometrial receptivity and thus impair endometrial receptivity. That's why we need to remove this polyp anytime you see in your clinical practice. So what are the instruments which are being used for this? Either you can use a cold scissor or you can use an electrosurgical cautery for the same. As these patients most of the time, if are infertile, it's always better to use cold scissors, and then you can remove it with the forceps, the endometrial polyp which is can be removed with the forceps. So whenever the polyp size is big or it has a feeding vessel, you can very well use electrosurgical cauterization with either monopolar or bipolar resectoscope, and these polyps can be removed very easily. And even if the size of the polyp is more than 4 centimeters, they can be removed easily. And nowadays the newer technology says that even you can keep this polyp inside the endometrial cavity and they can come out. So ideally cold scissors is best for the patient who is trying to conceive. Electrosurgical devices may be used like a morcellator for large polyp, which is going to be helpful for infertile patients. So here you can see one polyp which is there on anterior aspect and another polyp is on the posterior aspect. And hysteroscopic morcellator are the machines which can be used with the saline only, and it doesn't have any electrosurgical cauterization. So it is going to be helpful for the patients who are infertile. The hysteroscopic morcellators remove any size of the polyp with easily and with minimal trauma to the endometrium. So it is going to be helpful for the patients of infertility to hysteroscopic morcellator for these patients. And you can see this hysteroscopic morcellator will eat up and you have tissue for the HPR analysis for the patient. Even so many times there are multiple polyps which are there inside the endometrial cavity, which can cause increased trauma to the endometrial cavity if you remove it by hysteroscopic scissors or by electrosurgical equipments. These hysteroscopic morcellators are going to remove all these polyps without any endometrial trauma or minimal endometrial abrasion which can cause. So these are the polyps which can be removed easily by using a hysteroscopic morcellator. Maybe 2, 3 or more polyps also can be removed, but it will take slightly more time because it's a mechanical morcellator which is available. So morcellator is safe and effective targeted pathology removal under continuous visualization. It is continuous cutting and tissue removal, means only single insertion is necessary. That means if a big polyp is there, you are going to use a monopolar resectoscope or bipolar, you might have to insert your hysteroscope many times. So that advantage is there, and it is continuous hysteroscopic outflow and suction helps to maintain clear operative field and no tissue is floating within the uterine cavity, like if you are doing a hysteroscopic resectoscopic removal of the fibroids. So the another advantage is if the patient is going for a IVF in the next cycle, has no energy source is used, no damage to the endometrium, intrauterine adhesion formation is least. So I prefer to use hysteroscopic morcellator for polyps or even fibroids who are undergoing a infertility treatment. Hysteroscopic polypectomy remains the gold standard for the treatment. There doesn't appear to be differences in the clinical outcome with different hysteroscopic polypectomy techniques. Only issue remains is if you are using electrocauterization, then she can conceive after 2 months. But if you are using a scissors or even a hysteroscopic morcellator, she can plan pregnancy in the next cycle itself. So it is polypectomy in the subfertile women is effective in improving fertility with reported pregnancy rates varying between 43 to 80%. Spontaneous pregnancy and associated with ART always increases. Uterine cavity is healed by 2 months postoperatively, but there is insufficient evidence to advocate a specific length of time before a woman should conceive. And the management algorithm for polyp remains the same. If asymptomatic, there is no need of removal, but if symptomatic or patient is taking infertility treatment, then hysteroscopic polyp or more than 2 centimeter size has to be removed. What evidences says in IUI, the hysteroscopic removal of polyps prior to IUI increases the odds of clinical pregnancy. Hysteroscopic polypectomy increases rates in IUI cycles, in IVF cycle in women in whom the only reason for subfertility was endometrial polyp. Hysteroscopic polypectomy improved the rate of spontaneous conception regardless of size and number of polyps. And IVF polypectomy improves the implantation rate. Now we are going to discuss the second situation, which is going to be helpful, is a hysteroscopic submucous fibroids. As this patient has ultrasound, which is showing 3 into 2 centimeter fibroid size, which can be very well removed by hysteroscopy. The important points to be catered are what is the size of the myoma. I remove any fibroid which is submucous, which is grade 0, till a size of 3 to 4 centimeter. So if expert is there, they can remove polyps of more than 4 centimeter size also. What instrument you are going to use, whether a monopolar cauterization or bipolar resectoscope, or if fibroid is more, whether you are going to use a histrolab approach, that is very important. For that, you need to know what is the fibroid mapping, which is very important. A 3D ultrasound or in difficult cases, MRI also is going to tell you what is the exact size of fibroid, location of the fibroid, and accordingly you can graph it into this FIGO classification, which has 0 to 8 points. And if it is submucosal, 0 is pedunculated, which is simple by hysteroscopy. 1 is less than 50% intramural, can be removed hysteroscopically very easily. And level 2, which is more than 50% intramural, also can be removed, but sometimes second setting or decreasing the pressure of the hysteroscope is required. And those fibroid which are more than 3, that is 100% intramural, subscissor, laparoscopy route is better. So how we are going to decide which patients are going to be successful by hysteroscopy is by Lasmer's classification, where group 1 is 0 to 4, which is not complex. Group 2 is 5 to 7, which is complex, and group 3, 7 to 9, where always use a laparoscope. What is this Lasmer classification? It is going to predict whether a transcervical resection of myoma is possible, and that the point system, which is depending on the penetration, size of the fibroid base, and whether lower third, middle third, or upper third of the uterine cavity is involved, and then you give the scoring system. If the score is 0 to 4, low complexity hysteroscopic surgery is simpler. If score is 5 to 6, then complex hysteroscopic myomectomy, considering preparing the GnRH analog, or in some cases, a 2-stage procedure is required. And that is why the counseling is very important in this patient where fibroid size is more or they are deeply impacted. That's where a Lasmer classification helps. And when score is more than 7 or 7 to 9, then always you go for a laparotomy or laparoscopic approach. Why it is important to remove submucous fibroid? Because evaluation of the endometrium sometimes gives a clue regarding the underlying submucous fibroid, and they cause abnormal vascularization of the superficial. That's how Donnes has done studies where he has tried to address the issue, and there are 106 relevant articles which concluded that they do influence fertility, mainly based on the favorable pregnancy rate obtained after myomectomy. So submucous fibroid, the effect of hysteroscopic myomectomy, and factors which are influencing outcome. Hysteroscopy has the advantage that it diagnoses as well as they remove the fibroids in the same setting. Submucous fibroid significantly reduce implantation and pregnancy rate after ART. So submucous fibroid that distort the uterine cavity have been found to carry relative risk of 0.3 for pregnancy, 0.10 rate for implantation after ART. That's how they need to be removed. And whenever you are doing or planning a surgery, you have to know what is the position, and then the uterine receptivity, the pressure effect, blocking, whether it's blocking the tubal ostia, there is cytokine production occurring, and also poor implantation because of this fibroid. As I told you, T0, T1, T2 fibroids, where it is a correlation between the sonography and the ultrasound and the hysteroscopy report, where hole which is there as a pedunculated T0, more than 50% in 50% T1, and more than 50% is T2 fibroids which are there, which can be seen. So wherever you are planning or contemplating the submucosal fibroid removal, we have to see where is the location, number of myomas, size of myoma, whether it's symptomatic or asymptomatic, there is associated adenomyosis or endometriosis, whether it is distorting the endometrium, how many previous failed IVF cycle, previous pregnancy losses, and available expertise and resources, which is very important. If your setup has a hysteroscopic surgeon available, then it's always better. What is his expertise? How much size he can remove? That is what is important. And other factors like male factor has to be ruled out before contemplating a surgery. So what AAGL practice guideline for submucous myoma? Removal improves fertility, especially type 0 and type 1, but remains low as compared to the normal uteri, which is known. HAG is less sensitive and specific. Hysteroscopy is must. TVS is less sensitive. MRI is superior in classification relationship of myoma with the serosa, and cervical preparation can reduce the trauma, and pre-op use of GnRH agonist corrects anemia as well as reduces or shrinks the size of the fibroid, and that is why it is going to be useful for removal of this fibroid. As you can see, a simple posterior wall fibroid which is there, the quality is not slightly not good. So these fibroids can be removed by resectoscope, and then you can send it for histopathology. You can do an inspection and cavity at the end of the surgery, and you can see the whole fibroid has been removed. The resection of the multiple myomas, whether it is possible by a morcellator, no, it is not always possible by the morcellator. So you have to use first a transcervical resection of the endometrium, and these of multiple myomas can be removed by the surgery. Whether you can use a monopolar quadrization, then you have to look for the fluid deficit which is there. If the fluid deficit is more than 1 liter, then you have to stop the procedure. In saline bipolar, if fluid deficit is more than 1.5 centimeter, you have to, 1.5 liter, you have to stop the procedure there and there itself. The multiple fibroids, sometimes it is very difficult to remove in a single setting, but as far as possible, remove the first simple fibroids posteriorly, and then go like this for anterior wall fibroids. These fibroids would go in quick, come out quick. Don't remove the parts of the fibroids which are specules which are there inside. You can remove it at the end of the procedure because it will cause distension failure, and that is how you have to insert the catheter, insert the resectoscope inside many times, and that's what it causes the problems. Whether you can remove these fibroids a hysteroscopic morcellator. The question always remains, and debate always will be there. And the studies have shown that it has both has similar effect. And whenever you can possible, you can try with the hysteroscopic morcellator. But the only problem is if there is a bleeding, you have to go again with the resectoscope for quadrization of that bleeding part. But here you can see we can remove the hysteroscopic complete fibroid by morcellation of the technique. What to do for large myomas? Here the important is to take the consent for second setting in case it is required. First, try with the hysteroscopic morcellator as much of the part of the fibroid which can be removed with the hysteroscopic morcellator. It is safe as saline is a distension medium, and here you can see a 3.5 centimeter fibroid has been removed successfully with the hysteroscopic morcellator. What is the important thing is the morcellation cost is more. That is why it is not very easily available in every setup. But if available is there or hysteroscopic surgeries are done more, then it is always better to invest in such instrument which is going to be helpful for the hysteroscopic removal of fibroid as well as polyp. There is some newer technology called as dual approach. Whenever I find that hysteroscopy is showing a 4 centimeter or more than that fibroid, first go in with a hysteroscopic morcellator, try to remove the part, whichever part, how much of the part which is possible without any risk because you are using a saline. And once you have removed the part which is indenting into the uterine cavity, lastly, you can go ahead with the resectoscope, and then you can remove the part with the bipolar resectoscope. And that's how a dual approach where use of both technologies, that is hysteroscopic morcellator as well as you can use the resectoscope for the same, that is called as a dual approach which can be used. And wherever you have removed the fibroid which are more than 3 or 4 centimeter, it is always better to go ahead with a second loop scopy, so that sometime there are post myomectomy adhesions. If the fibroid is big, you can do a resection by either scissors, or you can remove these with the resectoscopy. Then we'll go to the third important case, which is there in a patient with Asherman syndrome, where patient has no menses as well as intrauterine adhesions. So what does Asherman syndrome cause? It causes hypomenorrhea, or many cases amenorrhea, infertility, recurrent implantation failure, recurrent pregnancy loss, preterm labor, fetal growth retardation, intrauterine fetal demise, and if conceived fetal abruption. So TVS is generally not very reliable diagnostic test, but it can show echogenic, irregular, eccentric lines with the endometrium, or as a focal narrowing of the endometrium thickness. On the right side, you can see calcific shadows, and 2D UAG is highly specific, about 95%. 3D UAG, the specificity is 45% and sensitivity is 87%. Should we consider SIS or HSG in the diagnosis, or directly proceed with the hysteroscopy to confirm the diagnosis? Wherever hysteroscope is available, where it is not available in the low resource country, where you can do a saline infusion sonography like this, the sensitivity is around 75% and specificity is 93%. The adhesions are characteristically appearing as a bridging bands of tissue that distort the cavity, and flimsy adhesions are described as thin undulating membranes which are seen. These are the routine pictures where any patient comes with the primary infertility or secondary infertility. If you do HSG, and on the left side, you can see a normal HSG. On the right side, you can see adhesions which are seen as filling defects, described as homogeneous opacity, surrounded by sharp edges, and do not change with the positioning of the patient. So ultimately, hysteroscopy remains the gold standard for diagnosis, because it is going to diagnose as well as you're going to treat in the same sitting. And nowadays, with the office hysteroscope, it is very possible that patient can go home on the same day. So these on hysteroscopy, mucosal adhesions are seen as frequently pink, like the surrounding endometrium, and easy to lyse. And fibromuscular adhesions appear as thicker and white bands. Those which are fibromuscular adhesions can be removed very easily with the scissors. So AGL recommendation for diagnosis of intrauterine adhesions is hysteroscopy is the most accurate method for diagnosing of intrauterine adhesions and should be the investigation of choice when available, that is level B evidence. If hysteroscopy is not available, you can go with HSG and SIS. MRI should not be used for diagnosis outside research setting. So this is a ASRM scoring for intrauterine adhesions, where you can see extent of the cavity involved less than 1/3, 1/3 to 2/3, or more than 2/3. The scoring is given from 1 to 4. Types of adhesions: flimsy and dense 1 to 4. Menstrual pattern, whether it's normal or amenorrhea, 0 to 4. And depending on this, a prognostic classification of stage 1 disease, a mild disease, is 1 to 4. Stage 2 is moderate, 5 to 8. And stage 3 severe as 9 to 12. And the prognosis of these will be depending on what is the scoring system. If you can do a good hysteroscopic correction, restoration of menstruation in 70 to 90% of the cases, pregnancy rate of 60 to 90%, term pregnancy 40 to 80%, and in Asherman, though, pregnancy complications are high if you are not done a good job, and recurrence is always there. So what is the pre-op preparation? Ideally, you can, if patient is menstruating, ideally to be done on day 7 to day 9 or day 10 of the cycle, and patient has to be counseled. As far as possible, regional anesthesia has to be used. The instrument is again cold scissors, and laterally if bands are very thick and scissors is not working, very thick bands, then prefer monopolar hook, or you can use a bipolar. So in these surgeries, whether to go for a hysteroscopic adhesolysis with assisted with laparoscopy, should we routinely put a laparoscope whenever you are doing a hysteroscopic adhesolysis? Those patients who are infertile, there are other diseases, is always better to go for a laparoscopy as well as hysteroscopy in the same sitting. But where 3D ultrasound or previous laparoscopy reports have shown that it has only intrauterine adhesions, then there is no need of laparoscopy for this patient, because direct visualization of the uterine cavity at hysteroscopy in conjunction with tool for adhesolysis is the treatment of choice for intrauterine adhesions. That is level B evidence of intrauterine Sanicam management of Journal of Minimally Invasive Gynecology. In the presence of extensive or dense adhesions, treatment should be performed by expert hysteroscopists, and there is no evidence that hysteroscopic adhesolysis guided by external imaging techniques like ultrasound or laparoscopy prevents uterine perforation or improves clinical outcome. However, such an approach used in appropriately selected patients may minimize the consequences of perforation if occurs. Post-op treatment is always better high dose of estradiol valerate that is given as 2 milligram thrice, 2 tablets thrice a day. And in few cases, wherever possible, you can use a pediatric Foley's catheter. Lippes loop is not available nowadays. The condition of Asherman was first diagnosed in 1894. The hysteroscopic adenolysis using scissors or biopsy forceps has the advantage that it permits dissection and avoid complication related to energy sources, and it minimizes the destruction of endometrium. Surgery that uses energy sources either with electrode or laser vaporization system could provide effective and precise cutting as well as good hemostasis, but there is a theoretical possibility of further endometrial damage. So you have to be very judicious whenever you are using an electrosurgery system. Monopolar cutting needle or Versa point bipolar are better for these adhesions. Whenever a surgery has been done properly, then the endometrial blood flow increases, the impact on endometrial receptivity is there, and significant improvement in the endometrial thickness was observed. High blood flow impedance of spiral artery perhaps impairs the growth of the endometrium, making it unsuitable for successful implantation. That is why a hysteroscopic surgery is going to help this patient to increase the blood supply. And these are few surgeries where it is seen that it is a most effective method, that is hysteroscopic adenolysis for any patient. This patient, I am showing it a general patient where there are intrauterine adhesions at the internal os, which can be removed only by the use of a hysteroscope, and you can remove as much as possible. Once you go inside and you can see the intrauterine adhesions, is always better to see both ostia. Secondly, try to formulate the T of the triangular cavity of the endometrial brain, and that's how you start cutting with the either scissors or by monopolar hook. And once you have created that the T-shaped cavity, then only you can stop. Once both ostia are seen properly, they are at the same level, your scissor moves inside the endometrial cavity towards both ostia, that is the end point of the surgery. Or whenever there is a bleeding which occurs, which is ideally from the myometrium, then you can stop the procedure. Whenever you are doing a endometrium, whenever you're doing the hysteroscopic adenolysis, is always advisable to give high dose of estradiol for this patient. But the only problem remains those patients with moderate to severe Asherman's, the recurrence rate is that is 3 to 23% for the patient. Use of an IUD keeps the raw dissected surfaces separated during the initial healing phase and may reduce the chances that will adhere to each other. In literature review, Lippes loop is better. You can put an intrauterine balloon post surgery like this, but this is just a video to show the post-operative Foley's catheter to be kept. The use of an IUD stent or catheter reduce post-op adhesion reformation. There are limited data regarding subsequent fertility outcome, that is grade A evidence. If an IUD is post-operative Lippes loop is better, and there is no evidence to support or refute the use of preoperative, intraoperative, or post-operative antibiotic, that is level C evidence. Semi-solid barriers such as hyaluronic acid and autocross-linked hyaluronic acid gel reduce the adhesion reformation. At this time, their effect on post-treatment pregnancy rate is unknown. Post-op hormone treatment using high dose of estrogen with or without progestin may reduce the recurrence, that is grade B evidence. And role of adjuvants to improve vascular flow to the endometrium has not been established. That means PRP stem cell is not been established, but there are research going on. Maybe in next few years, we can get good evidences about this. And stem cell treatment may ultimately provide effective adjuvant approach. However, evidence is very limited, that is grade C evidence. So recurrence rate is common, follow-up assessment is important. And after 2 to 3 cycles, you can do HSG or repeat surgery for the patients of intrauterine adhesions where moderate to severe Asherman is there. So what AAGL guidelines say? Hysteroscopic guidance is the method of choice with any tool. Laparoscopy may be combined in case of dense and lateral adhesions. Antibiotic, not a routine practice. IUCD or Foley is not recommended. Estrogen can be used to prevent recurrence. Hyaluronic acid gel can reduce adhesions, and reassessment of cavity after 2-3 cycle by office hysteroscopy is mandatory. So those patients, now we are coming to the last part of the lecture, that is about whether uterine anomalies. So uterine anomalies causes spontaneous miscarriage, recurrent pregnancy loss, malpresentation, and fetal growth retardation if there is a pregnancy. So first is septum. Whether septum can cause infertility or recurrent pregnancy loss. This is the case. Prevalence of septate uterus general population is 2%, infertile is 3.5%, and for abortion it is around 5%. All women with RPL should be assessed for uterine anomaly, that is RCOG Green Top Guideline of 2011 level C evidence. The more evidence says that all this study shows hysteroscopic resection of septum improves the pregnancy rate and live birth. Incomplete septum removal improves pregnancy, live birth, and lowers risk of miscarriage. Hysteroscopic metroplasty improves the live birth. Hysteroscopic metroplasty improves the live birth irrespective of the method used. And hysteroscopic metroplasty with residual septum of less than 1 centimeter doesn't adversely affect the reproductive outcome. So Cochrane review of 2017 says most studies of metroplasty for a septate uterus combined women with recurrent miscarriage and infertility, and no study has been published that randomizes infertile women to treatment versus no treatment. For this reason, controversy exists as to whether infertile women should undergo metroplasty. Again, most studies of metroplasty for septate uterus combine women with recurrent miscarriage, and no study has been published that randomizes infertile women to treatment versus no treatment. For this reason, again, their controversy remains. So how you are going to diagnose a septum? By 3D ultrasound, sonohysterography, or MRI. All are diagnostic tests for distinguishing septum and bicornate uterus when compared with the laparoscopy or hysteroscopy, that is level B evidence of ASR. In this, so what you are going to do radiologically, or you are going to put a hysteroscope. Here, this is very important ASRM 2016 picture, which is the picture for diagnosis of septum or bicornate uterus. The normal uterus is depth less than 1 centimeter. 3 degrees. Septate is depth is more than 1.5 centimeter. Angle is less than 90 degree. And important bicornate uterus where depth of indentation is more than 1 centimeter. So a simple 3D ultrasound done by a gynecologist himself or herself or a radiologist can diagnose whether it's a septate uterus or a bicornate uterus, and depending on that, you can give a prognosis to the patient. So again, question remains our mind: does the septum impact fertility? There is insufficient evidence to conclude that uterine septum is associated with infertility. Grade C evidence. Infertility can be result of multiple factors, so it is often difficult to say about one cause. But several observational studies indicate that hysteroscopic septum incision is associated with improved clinical pregnancy rate in women with infertility. So the last point remains in septum. Does treating a septum improve obstetric outcomes? Some limited studies indicate that hysteroscopic septum incision is associated with reduction in subsequent miscarriage rates and improvement in live birth rate in patients with history of RPL. So grade C evidence. So it indicates that hysteroscopic septum incision is associated with an improvement in the live birth rate in women with infertility or prior pregnancy loss. So any gynecologist or infertility specialist, whenever a patient comes to you, you have put a hysteroscope and there is a septum, because of this reason is going to remove this septum. Which instrument is better? What is the endpoint? Again, similarly, you can use with the hysteroscopic scissors, or you can go ahead with the bipolar, saline, or monopolar resectoscope. These are few videos where hysteroscopic septum resection is done with the scissors. As you can see, the endpoint is you can see the ostia, both ostia from the internal os in the same setting. Also, your Caesar or instrument resectoscope has to move from one ostia to the other ostia without hindrance. That means without any fibromuscular tissue which is available in between. And when should be pregnancy planned? You can again plan after 2 to 3 cycles. So this is a picture where you can see a saline bipolar is being used for the hysteroscopic resection. There are issues at Latur about the rain and also sometime my connection might get just lost, though I am on generator. So this is a patient with complete septum where you can see vaginal part is removed. I keep the cervical part, and that's how from other cavity we have put a balloon, and from opposite cavity we are removing this part of the septum. And once you see the balloon, then you can go ahead with the hysteroscopic septum resection. Lastly is the Robert's uterus, where you can see this cavity where is asymmetrical septum, where you can see only the single ostia is there, but on laparoscopy you can find that. So here on the opposite side we are doing a blunt dissection, and my Caesar has gone into the opposite cavity. Once I am into the opposite cavity, you can see both cavities are seen, and septum resection can be completed after that. So lateral metroplasty or in T-shaped uterus, again, in the cases of T-shaped uterus, the lateral metroplasty can be done, and this can be done with the scissors or resectoscope until you can see the uterine cavity properly. The converging walls again are being cut here, and that is a T-shaped uterus with metroplasty can be done. So the last situation is proximal tubal block, where screening test by HHG or hycoscopy can do a sensitivity or specificity. Proximal tubal block accounts for 15% of the cases. Corneal spasm can be in 20% of the cases. And treatment of this proximal tubal block is either by IVF or tubal surgery. That depends on patient's preferences, age, associated problem, cost, and risk of OHSS in this patient. So recommendation is for women with proximal tubal obstruction, selective salpingography plus tubal catheterization or hysteroscopic tubal cannulation can be done for these patients. So these are the videos of the corneal cannulation, where you can see anybody can do a hysteroscopic corneal cannulation with the cannula, and the diatesis is there, which is positive. The important thing is in secondary infertility cases where there are hysteroscopic morcellation of the bony spicule can be done. Ideally, it can be done with it was done with the forceps, but now we are doing with the hysteroscopic morcellator. All the tissues can be removed properly, and this is going to help for the patient to regain its menses, and this patient can become pregnant once you are done. So hysteroscopic morcellator plays a good role. Nowadays, it has advantage that it eliminates the need to remove the fragments in the hysteroscope, easier to master than conventional resectoscopy, preserve tissue for histopathology, but the only thing is grade 2 submyoma or cost is the only problem. This is the oscilloscope where it oscillates at 800 RPM, or reciprocating morcellator, which is moving at 1100. The next cycle can go for IUI or IVF. That is the important, that no damage to the endometrial cavity, and extra mile that it is going to be helpful for visual DNC, removal of the bony spicule, and removal of the RPOC. So this is a study done by Dr. Vidya Bhatt, which says hysteroscopic morcellator for removal of uterine submucous myoma offers good alternative, but both are similar. So ASRM recommends hysteroscopy is a definitive method for diagnosis and treatment of intrauterine pathology. It is though costly and invasive method for uterine cavity. Evaluation should be reserved for further evaluation treatment of abnormalities defined by less invasive methods such as HH. So routine hysteroscopy before IVF, what is inside trial says, routine hysteroscopy doesn't improve live birth rate in infertile women with normal TVS of the uterine cavity scheduled for first IVF treatment. Women with normal TVS should not be offered routine hysteroscopy, but those with the failures, there are success rate. So take home message is routine hysteroscopy should not be used. Intrauterine pathology should be addressed by hysteroscopic diagnosis and treatment. Hysteroscopic surgery increases chance of pregnancy and live birth by either spontaneously or after IUI or after IVF. Vaginoscopic or no-touch approach has several advantages. Hysteroscopy is safe, cost-effective than conventional surgery. So any patient with infertility, it is going to have beneficial effect of doing a surgery by hysteroscopy. I thank Dr. Monica Umbardhan and organizers for giving me this opportunity. As there is no light in Latur and there's a lot of storms going on, my lights have gone. Thank you so much. Yeah.
Thank you, sir. Sir, before we take the chairperson's comment, I would like to introduce our chief guest, Dr. Prakash Trivedi, sir. He is the director of Trivedi Total Women's Healthcare Hospital and Akar IVF Center. He is also the professor and head of the department at Rajavali Hospital. He was the president ISAR in the year 2021. He is also a FIGO Regional Ambassador and Endoscopy Committee Chairperson, President of FOXI for the year 2015 and IAG in 2013 to 15. He has been the scientific chair of AAGL in India in 2016 and 20. We welcome you, sir, and ask you for your blessings for this webinar.
I hope I am seen on heard.
Yes, sir.
Because
Yes.
I am at Bella's resort. I have to give a talk to 150 people shortly, but it gave me time where I could hear our dynamic man whom I always call आता light मध्ये नाही, कल्याण bar मध्ये पण नाही. So Kalyan's talk I could hear, and as it is related to infertility and it's an educational event, it's my honor to be the chief guest when I am actually enjoying the weather and other aspects there at Bella's resort. The lecture will start and all of you are very good speakers and panel. So we wish you a lot of success. Fortunately, it's raining here, but lights are on. Thank you.
Thank you so much, sir, for joining us and being patient with us and waiting all the way here till Kalyan sir's talk was over. I now request Sudha ma'am and Kiran sir to please give the concluding remarks for sir's talk and introduce Jay sir.
Yeah, Dr. Kalyan, I think this was a really elaborate talk, and you have very nicely covered everything in hysteroscopy in spite of the problems that you had of not having light and brains and everything over there. So I think you've done an excellent job. Really keep it up. And I think the time has come where hysteroscopy should be offered to all patients, whether they are in a metro city or in a rural setup. I think there can't be any excuse that, you don't have equipment, you don't have, expertise. I think one should buck up and do hysteroscopies for almost all cases, whether it is infertility, AUB, postmenopausal bleeding, etc. I think you've done an excellent job and really told everything in detail. One thing which I would like to ask is a few things, sometimes we come across hyperemia or multiple polyps, micro polyps suggestive of chronic endometritis. So what do we do in such cases? Or somewhere in an adenomyoma, so these cases, how frequently have you encountered and what would be your, surgical tips in these cases?
Those patients with chronic endometritis or multiple polyps, firstly, giving antibiotic is important. Secondly, I use something called as manual vacuum aspiration. This is a syringe which comes and I put this syringe and have a pressure and remove these small polyps because these are because of the hormonal changes. And this polyp can be sent for histopathology. And if patient has already finished her childbearing, then I put them on LNG IUS device for 3 to 6 cycles, ma'am.
Yeah. Basically, I was talking of chronic endometritis in infertility. And then, because your talk was of infertility.
Yeah. So what happens, ma'am, in chronic endometritis, giving a good, taking a biopsy and giving a good antibiotic is important. Secondly, those patients with so many, see, if there are multiple polyps inside and you can't take biopsies at every point. So it's always better to use an instrument which causes minimum trauma to the endometrial cavity. That is what is mine.
Yeah, I think just taking a simple biopsy of one of the polyps just for diagnosis is important, and then give them antibiotics. I think, yeah, correctly said. Dr. Kiran, would you like to add anything, comment?
No. Kalyan has almost covered everything, and Kalyan is the star boy of AMOGS, and we are really proud that whatever he is doing is excellent. But as you rightly said, Kalyan, the last 2-3 slides that you mentioned about the morcellator, yes, I would definitely agree that gradually the morcellator could replace the resectoscope. Only the issue is about the affordability, but I guess Medtronics and other people, storage people, with the pressure of IAG, they can do something for all the gynecologists.
Yes, thank you, sir. Because as many people will start buying, the cost will come down. That's what is.
Yeah. Thank you.
Thank you so much, Dr. Sudha ma'am, Dr. Vivek sir, and Dr. Kiran sir, for all the for being chairperson for this session. And now we invite Dr. Jay Mehta, who is a star of IAG and laparoscopy.
Kiran sir, can you please introduce Jay sir?
Yes. Yeah. This is the slide of introduction of Dr. Jay Mehta, who has done his post-graduation from KEM Hospital. So from undergraduate of KEM Hospital, Mumbai, PG for Jubilee Mission Hospital. He has done his laparoscopy training at Trishul, Kerala with Dr. Ashwath Kumar. He has got a fellowship in male infertility from USA. And this is the standard biodata of Jay. But the Jay that I know is something different. Yes, he has embarked on the Project Pelvis, which has got more than 10,000 members by now. His gynae group of gynecologists has more than 14,000 members, and the kind of education that goes on in that group is just phenomenal. I would say that he is an all-rounder doing more work, not only in obstetrics and gynecology, but also in endoscopic surgery and IVF. And probably he is the prodigy and new kid on the block, probably. So Jay, I hope you're listening. You're muted right now, but I hope you're listening. And last but not the least, everyone has seen the movie Three Idiots. Okay, everyone has seen the movie Three Idiots. And had I been Boman Irani and did I have a pen, then I would have given it to Jay, because that is the kind of work that he is doing, and just phenomenal. And probably everyone of us must try to emulate. I don't know how many of us would be able to achieve that, but everyone must definitely try to emulate whatever he's doing. I've observed him recently, yesterday only, and today, in fact, as he logs on, he has just finished a very complicated surgery of endometriosis. So I think that's all from me right now. And Jay, over to you for your talk.
Guys, thank you so much, and amazing presentation by Kalyan sir. He's a very close friend of mine actually, and Kalyan sir knows me ever since I started practice. So it's so good to listen to him, and he always speaks and gives such fantastic points. And thank you to Sudha madam and Kiran sir for and Pratibha madam for having me. So actually, what has happened is I have left the surgery midway, because I think Kiran sir had messaged on the number that your talk is about to start, so please come out. And I have left the surgery midway, and I'm coming for this talk. So just in case something happens, I might have to go back to the OT again, because it is somebody with a ruptured endometriosis on after giving Lupride injection, and she's a young 20-year-old girl who has gone in for intestinal obstruction with the whole peritoneum full of endometriosis. So I might have to go. And on top of it, as Prakash sir mentioned, here in Ghatkopar, it is just raining like crazy. So I'm actually connected to this on my phone internet. So I don't know if I don't even know if my audio and video is clear to all of you. So I just hope it is clear, right? And
Yes.
so today I have been asked to speak on fertility enhancement surgeries in laparoscopy. And as we do for all surgeries and all presentations these days, I will give the take home points first. Okay, so just in case somebody gets bored, of me in 5 to 7 minutes, you already have the take home points ready to take home, right? So as far as fertility enhancing laparoscopic surgeries are concerned, I really think that I think Sudha madam mentioned one very important line, that you cannot give an excuse that you don't have adequate instruments. You cannot give an excuse here that you do not have adequate training. Okay, and when you cannot give this excuse, these two things are very, very important for fertility conserving surgeries. Because in fertility conserving surgeries, after removing, let's say, the fibroid, after removing, let's say, the endometriosis, or whatever you are trying to remove, after removing adenomyosis, you are also going to give a lot of importance to the fallopian tubes. And if you want to operate onto the fallopian tubes nicely, that involves a lot of precision, and it involves a lot of delicate handling with good instruments, because your surgery cannot cause an iatrogenic damage to the fallopian tube. All right, so that is something which is very, very important. And the first take home point should be invest in good instruments, have appropriate training in order to do a fertility enhancing surgery. That is the first point. The second point, which I have always mentioned, is that in fertility, I do not, for people who don't know, I also do IVF, and I also do a good volume of IVF. Okay, so I am not just an endoscopic surgeon as is projected. I do IVF, I do IUI also. Okay, what is very, very important for people to understand is that there is no guideline anywhere on earth, whatever the best one which you like to follow, ASRM, ESHRE, whatever you want to follow, there is no guideline which states that do an incomplete surgery and come out. Okay, the guideline will state that if in case you have planned for surgery, achieve surgical completion. Because once you have surgical completion, be it endometriosis, be it fibroid, be it adenomyosis, or be it whatever which you can do with laparoscopic surgery, if your surgical completion is good, and if the tubal factor is taken care of due to whatever reasons, and if the male partner is normal, these couples really benefit with natural intercourse cycles and really benefit with IUI. They need not be pushed for IVF. There is no indication to push them for IVF. Okay, and I think this in today's time and age of webinars, this is going to be understood very frequently, because there are a lot of IVF clinics now, and because there are a lot of IVF clinics, patients do a lot of window shopping before doing IVF. So if there is no indication for IVF, you will always have 4 or 5 good consultants mentioning it to the patient that probably an IVF is not indicated, you may do with IUI. Okay, so keep that in mind to do a good fertility enhancing surgery. Okay, now I will cover take home points for fertility enhancing surgeries for fallopian tubes first. As far as proximal tubal block is concerned, and once proximal tubal block has been released by your tubal cannulation, it will just take you an additional 1 minute to perform a falloposcopy of the fimbrial end of the fallopian tube. Okay, I know commonly this is not practiced, and I also know that commonly this is not performed. But if the fimbrial appearance of the fronds inside is good, you can really go and tell this patient that they have a good chance of becoming pregnant, either with natural intercourse or with IUI. So keep that point in mind. We've shown multiple videos of that on our Facebook group. It's a very simple procedure to do with a simple 2.9 mm hysteroscopic sheath, and you will give your patient a huge amount of benefit should you be doing that. Okay, so that is one important point. Second, a lot of times what is reported on HSG or SSG as a mid-tubal block is basically when you put in a laparoscope, it is going to turn out to be some peritubal adhesion here or there, which has caused that tube to get kinked there, or it is going to be endometriosis. So if it is a mid-tubal block and if all other parameters seem to be normal, then you might as well do a laparoscopy. And trust me, 50 to 70% of the times, just your dissection of the fallopian tube will restore the anatomy of the fallopian tube. Once the anatomy of the fallopian tube is restored, whatever anti-inflammatory medicines you are providing to the patient at the end of the procedure will take care of that anti-inflammatory changes of the tube for the next 1 month or so. And these patients can also become pregnant or attempt a pregnancy naturally. And that is something which is very, very important. Okay. A common small misconception about a hydrosalpinx in a fallopian tube. See, practical purposes, we always cut the hydrosalpinx rather than just clipping it. Okay, I don't go and just clip the hydrosalpinx. I don't go and at least just burn the proximal end of the fallopian tube with the bipolar. If you are going in for a hydrosalpinx or a hematosalpinx, for heaven's sake, just remove that tube and come out. The reason why I am telling this is that concept that it is going to do some damage to the ovarian reserve is not going to happen if you are flush to the lower end of the fallopian tube. That mesosalpingeal vessels, they do not mix with the ovary at all. Understanding? But if you leave that tube behind, it's commonly seen. We get at least one case every month where hydrosalpinx has been clipped and it has got converted into a pyosalpinx. Okay, and that pyosalpinx then causes localized peritonitis and patients end up with salpingo-ovarectomy. Okay, and this is very common. So if we think that this rarely happens, it doesn't really happen. It's something which is very, very common. Okay, all right. After we finish the fallopian tubes, if we move back to the fibroids, now typically all fibroids which are operable as far as fertility is concerned, or as far as enhancement of fertility is concerned, the most important thing you are supposed to remember is that do not leave any dead space inside the cavity. If you open the endometrium, it is okay. In fact, it is good. If you open the endometrium and if there is some bleeding inside the cavity, it will come out through the uterus. Understanding? There is nothing that, oh, I had a, let's say 5 millimeter cut on the endometrium and now there is going to be a problem in fertility or there is going to be a problem in implantation. There is no such thing. Understanding? You can open the cavity bindas. Nothing is going to happen. Absolutely nothing will happen to the patient. But don't leave any dead space in the myometrial bed. The dead space in the myometrial bed is going to heal with fibrosis. And once something heals with fibrosis, that is something which is going to really deteriorate the obstetric outcome of that patient in the future. Okay, so please keep that in mind when you are doing something related to a fibroid is concerned. Okay, I will again move on to one take home point which I was just writing down before the session started as far as adenomyosis is concerned. See, I have always told this in multiple occasions and events. Adenomyosis has two subtypes. One is the globular adenomyosis, okay, and the second is focal adenomyosis. Now, focal adenomyosis has two subtypes. One is the focal adenomyosis restricted to the inner myometrium, okay, and second is focal adenomyosis of the outer myometrium. There is no question in this thing, okay, there is no doubt, there is no question. This can be easily identified by ultrasound. For heaven's sake, if it is a focal adenomyosis which is more than 4 centimeters, patient has to get operated with endomyomectomy. You cannot leave the endometrial part thinking that what will happen to the cavity. Nothing will happen. You have to do endomyometrectomy in order to remove the adenomyoma along with a part of the endometrium. This is absolutely take home point. Second take home point, if it is a focal adenomyosis of outer myometrium, okay, then 100% you are supposed to do adenomyomectomy with flap resection. Okay, there is no second thought to it. If you are so much fan of Lupride and Dynogest, and even if you want to inject Lupride inside the adenomyoma, okay, even then it will only cause a temporary reduction in the volume and nothing more than that. The role of giving Lupride injection is good when you have to do globular adenomyosis and you have posted the patient for an embryo transfer and you want to achieve some volumetric reduction in the size of the uterus. That's it. The minute the effect of Lupride goes away, uterus will go back to its original size. And even Lupride is not recommended for an adenomyotic uterus which is more than 11 centimeter in size. Okay, so do not extrapolate indications of medical management based on our convenience. Just because we are speaking guidelines, I'm just presenting what is written in most of the guidelines. Okay, and finally, when we come to take home points of endometriosis, there is no role of just doing cyst drainage, okay, and coming out. There is no role of doing cyst drainage and giving Lupride and coming out. If you have decided to do surgery for endometriosis, remember, if all this is present, then this patient is also going to have associated pain. Okay, your pain to the patient does not go away by doing cyst drainage. The pain goes away when you remove the nodules and when you remove the implants of endometriosis. That is the only mechanism in which the pain will go away. Okay. So no matter what you try, okay, no matter what you try, I have seen, I'm right now, I'm just left the OT and come out of operating somebody who has been on Dynogest for 18 months. It is only a 13 centimeter endometriotic cyst. Okay. She has been on Dynogest. So what Dynogest will do? Dynogest will make you pain free, but Dynogest is not going to reduce the size of the cyst. All right. Then because she had pain on Dynogest, the doctor said no role for doing surgery. We will give Lupride injection. And the Lupride injection is going to cause volumetric shrinkage. So that shrinkage caused the wall of the cyst to rupture. She ruptured and she fainted. She fainted and she was taken to Lilavati hospital today morning. Okay. A CT scan was done, which showed query fecal peritonitis out of nothing. Okay. And because it was query fecal peritonitis with past history of endometriosis, the medical ICU guy thought that, okay, if it is something like this, let this go to Jai. Understanding? And that is what we have just now operating. In fact, after I finish this, I'll go and finish that surgery. So if you are really a fan of giving medical management, give medical management when it is indicated. Do not give medical management based on our indications. Understanding? As Sudha madam said, it was a beautiful point. I really wanted to tell this, and Sudha madam is like my family, so I can borrow her lines and copy paste it, that you have to invest in surgical skills. You have to invest in your instruments, and you have to invest in the right technology to treat the disease in the correct manner. Because if you are not able to do this, most of the times you will do a half job. And people who say that I did something and I gave Lupride and patient is so happy that the patient did not come back to me is actually wrong. Patient did not come back to you because patient either came to me or went to Sudha madam and got a complete surgery done for endometriosis. Okay, so that is the reason the patient did not come back to you. Okay, so please keep this take home point in mind. I think this is something which is very, very important as far as fertility enhancement of the endometriosis surgeries is concerned. Last one point I want to add, whenever in IVF people speak that even if it is grade 4 endometriosis, I don't like to operate. I like to make the embryos first. They are absolutely right in telling that. In IVF, you create, if the patient is for IVF, you create your embryos first, freeze the embryos. If the patient is having pain, then go and operate. Relieve everything, keep the uterus clear and everything, and then do embryo transfer. If the patient is absolutely painless with a frozen pelvis, then you may defer a surgery. The word is you may defer. The word is not you should defer. Understanding? So just keep that in mind if somebody is posted for endometriosis and has a frozen pelvis. All right. So that is another important take home point which you have to keep in mind. And finally, before I finish all the take home points, I want to give one very important take home point. All patients in whom you are doing fertility enhancing surgeries, okay, without fail, when you put a laparoscope, please put a hysteroscope also. Okay, never come out of these patients without doing a hysteroscopy in these patients. It is going to be, you are going to get amazing combinations when you do a laparohysteroscopy for all these patients. And you are going to never, you should make it a rule to never come out without doing an operative hysteroscopy or a diagnostic hysteroscopy in all of these patients. One more thing from medico-legal standpoint, and I always believe in medico-legal things because I think I'm the person who has faced the maximum number of cases. Okay, so what typically happens is you should take procedure specific consent. Do not take a random one paper consent for your fertility enhancing surgeries. Take a proper procedure specific consent. Do an AMH if your fertility outcomes may be compromised post surgery. Do not let the patient come on table without doing a fertility evaluation of all the markers before you take the patient in for surgery. Okay, so I think with this probably I would finish, and I would be happy to answer questions or discuss some things more if we have the time.
Fantastic talk, Jay. Any questions that we have from the delegates?
So I think videos all can see on YouTube also, no?
Fantastic, Dr. Jay. I think your take-home message was so brilliant and so specific to the point that I think we have really learned a lot from your take-home messages. And are there any questions from the audience, Dr. Monica?
No questions as of yet.
Okay, so can I just, ask few questions? Yeah.
Sure, ma'am.
Yeah. Dr. Jay, I think I starting from your last point, I think I missed mentioning it that all patients of laparoscopy, all patients of infertility, when you're doing laparoscopy, hysteroscopy is of prime. You cannot not do it. You have to do it. You have to have all the equipment, and also you must have all the equipment for doing operative hysteroscopy. There could be just a polyp, there could be adhesions and things which even you are not thought of, or it has not come up in your routine HSG. So I think not just a diagnostic hysteroscopy, but operative hysteroscopy also, you must have everything ready. And no excuses that, well, this was not ready and all that. I think that was a very good point. Then coming to your DIE and embryo transfer, I would like to ask you, patient has grade 4 endometriosis, you have the embryos in hand, but she doesn't have any symptoms. I feel it is always better to operate and take care of all the nodules. And I feel the success rate of pregnancy improves after you have done a clearance and then do your embryo transfer. What is your take on it? Patient doesn't have symptoms. So
if the patient doesn't have symptoms, the patient still has a retroverted uterus. Okay,
Yes.
in most of the situations. And even if there are no symptoms, actually there are symptoms. Now study these patients on ultrasound and you will see on a good ultrasound, if you reduce the gain, you will see that this patient have enhanced uterine contractility. Okay, so when these patients have an enhanced uterine contractility, your outcomes of embryo transfer are going to go down. Okay, if you mention this word and give it to the patient in writing, he will come today evening and get operated. Okay, because nobody wants to compromise the outcomes of IVF. I understand these guidelines are good for ESHRE. These guidelines are good for Portugal, where endometriosis surgery is not allowed to do fertility. Fertility surgeon does not know anything about endometriosis. Understanding. And the entire country of Portugal does less IVF than what you and me together combined do, madam, in the whole month. Understanding. So those guidelines are good only for those type of people. This is for practical purposes for Indian patients where cost is a big issue. Patient wants to become pregnant in the first cycle. Understanding. And if patient wants to become pregnant in the first cycle, you should restore the anatomy. And in order to restore the anatomy, you must ideally go and operate, remove all the nodules. It reduces the chemokines, it reduces the endotoxins, it makes the uterus back to its original shape. And trust me, I don't have any that randomized study and all those things to prove my point. I can only give you my logic. Okay, and trust me, it improves the outcomes, because whichever IVF center I go to operate, everybody calls me that you come, please do that, because last time you did that, that patient became pregnant. Understanding. So that means somebody must be getting pregnant out of it.
Right. So I think that was a very important take-home message. And always the conflict, or the debate, whether you do a medical management or you give a surgical management for endometriosis, I think that debate will go on. I think very important is that, the person, or you see the patient as a whole, not just whether I'm a laparoscopic surgeon or whether I'm an IVF surgeon. You see the patient as a whole, and then you offer the best what is to the patient. That is what I feel, and not just, if they just go to fertility specialist, they just talk of freezing the embryos and putting the embryos back. So I think both are complementary to each other. The surgery and the fertility treatment is what I personally believe. And I think whatever you've told about the tubal surgery, very good take-home messages. But only thing is that you must tell them there could be a risk of ectopic after you've done the tubal surgery.
I forgot to mention that point, madam.
That is one important point, because even if you do a corneal catheterization, tubes are open.
There is a 10% risk, madam, of ectopic.
There is a risk of an ectopic. And if they know, probably, that can be detected early. Yeah. So, Dr. Kiran, would you like to comment on any?
No, I think we are getting late. I mean, Jay has covered practically everything, and you have summed it up quite nicely. Thank you.
Vivek sir, do you want
Thank
to
you,
add?
Jay, and
thank you very much, all the chairpersons. That has been very noteworthy. Your points have been have reached us very well. Dr. Jay, it was a very nice and a crisp talk. on fertility enhancing laparoscopy. You have touched literally all the points, and you have just given a bird's eye view on when we go in, what should we exactly do to enhance fertility. Thank you so much, and thank you so much all the chairpersons, Dr. Sudha Tandon madam, Dr. Vivek Pitkar sir, and Dr. Kiran Kurtakoti sir. I think now we can move on to our panel discussion. For a panel discussion, I request Dr. Monica Umadan to please invite Dr. Charmila Ayuvyu madam, who will be conducting and moderating the panel.
Thank you, Pratibha. At the first instance, I would like to thank Charmila madam for accepting our invitation as a faculty. She is the Vice President-elect for FOXI for the year 24. She was also the Chairperson of Clinical Research Committee FOXI 2016-18. She is a part of the ICOG Governing Council member for the current year, and she's a National Coordinator for UNICEF FOXI PCA, the MEDA FOXI PG program, ISAR Gurukul programs for this current year. She is also the series convener for ICOG journal clubs and ICOG certificate courses. She is a WHO Southeast Asia Region India member and the past secretary of the Trichy OBGY Society. She is a president of Menstrual Hygiene Management Consortium in the year 1820. We welcome you, ma'am, to conduct this panel. Pratibha, I would like to you to introduce all the panelists before ma'am starts the panel discussion.
Okay, Mr. Sachin, can I have the slides of all the panelists, please? I invite all the esteemed panelists for today. Dr. Ashish Kare sir, we very well know him. He is the director of Asha Kiran Hospitals, Pune and Baner, and he's a founder, member and librarian of Maharashtra Chapter IAG, executive member of National IAG 2019-21, an executive member of Maharashtra ISAR, MISAR 2020-21, and he's presented many papers, posters, and he also has a Facebook Live where we keep seeing his videos and learning IVF from him. I welcome you, Dr. Ashish.
Thank you, madam. Thank you.
Next panelist is Sachin. Can I have for the slides? I have Dr. Reshma Rajbhoi from Satara. She is a director and consultant of Satara Yash IVF and a very good friend of mine. I have met her during many conferences and I have heard to her many of the times. Welcome you, Dr. Reshma.
Thank you so much, ma'am.
This is myself and now Dr. Chinmay, but I think Dr. Chinmay has not joined. Dr. Chinmay, have you joined? Okay, I have another very good friend of mine, Dr. Mansi Medikar. She was my UG, she was my PG batchmate when we have studied together at KM Hospital, and it is nostalgic to see her here today. She has done her diploma in advanced gynecological endoscopy from Kiel, Germany, and she has special interest in gynecological endoscopy and infertility. She is a member of Managing Council MOGS, and she has received Dr. Durusha Best Committee Member Award in 2020-21 and many more awards. She's attached to many hospitals at Mumbai like Lilavati Hospital, Surya Hospital, Shushruta Hospital, and many more. I welcome you, Dr. Mansi.
Thank you, Pratibha. It's really nice to see you. Thanks.
Nice. I have Dr. Aditya Khurd on the panel. He is also a very close friend of mine and son of Dr. Sanjeev Khurd, who is a best friend of my father-in-law too. He's a consultant gynec endoscopic surgeon at Khurd Endoscopy Fertility Center. He has done his fellowship in minimal access surgery from Paul Hospital, Kochi. He has done his fellowship from Bengaluru, and he has won the best paper prize at 12th AAGL, RCOG, and many national conferences. He has presented papers at international national conference. I welcome you, Dr. Aditya. Are you there? I think he's not joined. And I think Dr. Nilesh, is he there? I think he was also busy, so he had just dropped in a message.
Sir will going to join, ma'am. They disconnected just 5 minutes before.
Yeah. He was not going to join. It's okay. We can have the next panelist, please. Yeah, Dr. Adinath Rajguru sir has joined, and he is a very esteemed and a renowned infertility specialist from Osmanabad. I welcome you, Rajguru sir. Please put the slide of Dr. Adinath Rajguru. Yeah. He is the past president of IMA Dharashiv Osmanabad, and he is the past organizing secretary of MRCOG conference or Osmanabad. He has been a faculty in AMOGS, Yuva, Foxy, and many of the ISAR conferences. And he was awarded with Award of Excellence by auspicious hands of Joint Secretary Health, Government of India on the occasion of International Women's Day, Delhi. And he has participated in live telecast in Sakhi Sayadri and Doordarshan channels. We welcome you, Adinath sir.
Thank you, Dr. Pratibha.
Yes. Last but not the least, we have another panelist for today, Dr. Kekin Gala. He is attached at Saifi Hospital, Bhatia Hospital, Wokat Hospital, Basina Hospital, and SRCC hospitals in Mumbai. And he has special interest in fertility, high-risk pregnancy, and laparoscopy. We welcome you, Dr. Kekin.
Thank you, ma'am. Thank you, ma'am.
Over to Dr. Chadbila, madam, to please start the panel.
Thank you so much, Pratibha. I'm seeing that I have Dr. Ashish Kale there, Dr. Pratibha yourself, Dr. Mansi, Dr. Reshma, Dr. Adinath, and Dr. Kekin, right?
Yes, ma'am.
Yeah, we will not go elaborately because even the laparoscopy talk, I think, was done with only messages. But we will have a very interactive panel where we will get your opinions, because we know that whatever you do in of optimizing IUI and IVF to get the good results, it doesn't happen all the time. But there are things which you should not do, which may not help also. And that we know that many centers are doing, which may not be helpful. So I would like to know the opinions of the panelists regarding every method. Dr. Prerna was supposed to do on IUI. I think she's not joined. I will do IVF. And if there's time, we'll do IUI. Otherwise, we'll stick on to IVF. Welcome, Dr. Ashish Kale, Dr. Reshma, Dr. Pratibha, Dr. Mansi, Dr. Adinath Rajguru sir, and Dr. Kekin. So this patient, she's a 33-year-old. They are like 5 years trying for a pregnancy. The male factor is quite normal. They did they came with a HSG report, which was done elsewhere, and they were advised assisted reproduction in another center. So can I ask Dr. Ashish Kale, is there anything other than ART that you can offer this couple?
Madam, there is two things on the HSG. I can see there are the age of the patient is 33 and 5 years of infertility. On HSG, there is maybe a hydrosalpinx I can see on the right side.
Yes.
The left side is the tubal spill is okay. So
you think there's an hydrosalpinx there, the left tube?
Yeah. So that's the positive.
It's bilateral or unilateral, you think?
Yeah, I can see on a unilateral is much more evident rather than the bilateral. But there is a kinking of the tubes on the right side. So I want to evaluate her because of the two things: is a hydrosalpinx, whether there is an infective element is already been there. We know hydrosalpinx because of the infection. And secondly, hysteroscopy prior to going for the directly to the ART procedure, it is better to find out whether there is a endometritis or not. So I will wish to go with the, provided the male factor is taken care of, we will be going for, we are going for the hysteroscopy and the specific test to know the endometritis.
And then laparoscopy is needed or not needed?
Yeah.
What are you going to do about the tubes?
Yeah, tubes definitely. If it is a evident hydrosalpinx, that what I can see on the unilateral is very much evident, I will put a laparoscope and do a salpingectomy for that.
Yes. The couple is actually going abroad in another month, Dr. Pratibha, but they want to do the treatment as soon as possible. They're not willing to wait even for the histolap. Is that right? Would you like to do the ART directly, or you will convince them for a laparoscopy, as Ashish said?
They have to be convinced and counseled that going directly for IVF will decrease the chances of conception. It will lead to failure. So it is better that we get a hysterolaparoscopy done and go in a stepwise manner. They can go back very well abroad and then plan their next visit when they can buy more time and come and do the complete procedure. So hysterolaparoscopy first, remove the damaged tubes and then go for IVF. Otherwise, they will have a failure of IVF.
Any other opinion from the other panelists, or all of you agree with Ashish and Pratibha? Anybody would like to disagree? All agree?
Yes. Yeah, ma'am, you can counsel them, and maybe if she's here for a month, this month they can go ahead with the laparoscopy, and once they come back, you can go ahead with
so you actually agree with both Pratibha and Ashish then? You're not disagreeing?
Yes.
Okay.
No.
So there's no conflict at all. I wanted a controversy there. Nobody's willing to step in there. Okay. Actually, what everybody said is right. You should go ahead with the salpingectomy when you're considering IVF, because if you have a hydrosalpinx there, it's known to have a detrimental effect on IVF success rates. Pregnancy, implantation, delivery rates are actually lower when you have hydrosalpinx. And they say that's because of the mechanical flushing of the embryos from the uterine cavity, the decreased endometrial receptivity, which can happen because of the toxic fluid, or actually a direct embryotoxic effect also. And if it's visible on an ultrasound, not even on a HSG, it's definitely needed that you do remove the hydrosalpinx before you go ahead with IVF. And many RCTs have proved that if you do a salpingectomy before IVF, if you have a hydrosalpinx, it restores rates of pregnancy and live birth. And sometimes even spontaneous conception can happen if it's a unilateral hydrosalpinx. That is also known to occur. And I would like to ask Dr. Mansi now, what is your preferred method? I think we had a talk by
Dr. Jai Mehta has already.
Dr. Kalyani. Clipping or salpingectomy?
No, ma'am, salpingectomy. Jai Mehta has also said it. There is no role of clipping because the fluid does damage even if you clip it. And then in future, this.
How will it damage if you clip it? How is it going to come back into the uterine cavity? I can't understand that logic there.
No, sometimes the fibrillar end also keeps on oozing, no? So that side.
But it will ooze into the peritoneal surface. It's not going to ooze into the uterine cavity where you're putting the embryo.
Yes, madam, that we are not worried about the embryo, but even the oocyte quality can get affected if you have a hydrosalpinx. So it's better to do a salpingectomy.
No, the other ovary will be good, na?
Ma'am, it's better to do a salpingectomy in such cases. And then Dr. Jai Mehta said there is no role of clipping. If you do it very close to the tube, there is no role of damage to the ovarian blood supply also. And these patients later on, even after pregnancy, if they conceive also later on, they have some of the other issues. Another thing which gives you, when you do a salpingectomy, edge is that when you send that tube, suppose there is a COX or histopathology, which is suggestive of COPS, you get a tissue. When you are doing only a clipping, you're not getting any tissue for sending it for any further investigations.
So you need not even do a salpingectomy. You can take a bit of tube also.
But ma'am, I do prefer doing only a salpingectomy only.
Okay,
I don't prefer clipping
not
at
able
all.
to convince you otherwise. Pratibha or anybody else would like to disagree with Mansi?
Sometimes it can lead to a
salpinx. So that's why you remove the
just with the clipping.
All of you will do only a salpingectomy. None of you will do a clipping. Dr. Adinath or Dr. Kekin?
Yes, I would like to do the salpingectomy rather than the clipping.
Clipping, okay. Dr. Kekin?
Salpingectomy, ma'am.
Salping. All of you are convinced with Jai Mehta then. Yes. Nobody wants to disagree. Suppose you're not able to take out the salpinx fully, there's a tubovarian mass.
Madam, can I talk to you?
Yes, Ashish. Yes.
Yes, ma'am. I do have some things related to the clipping and some points to the salpingectomy.
Yeah.
So it depends upon how much tube is a hydrosalpinx is evident by.
Yeah.
If it is a terminal hydrosalpinx, it is definitely you will be doing the salpingectomy. If it is a proximal or maybe a middle hydrosalpinx where there is a minimal hydrosalpinx which is evident, when you put the scope, the clipping also shows the similar results as far as the pregnancy outcome is considered. Not all the times the salpingectomy is needed.
Yes, perfect. Yeah. So proximal tubal occlusion, as Ashish said, may be an alternative. You need not think that only a salpingectomy is going to help according to the ASRM practice committee opinion. It's not my opinion. And there were 2 RCTs which reported that proximal tubal occlusion was equally effective in restoring IVF pregnancy rates in women with hydrosalpinx. As all of you said, there is a concern that proximal occlusion may lead on to an increase in the size of the hydrosalpinx, or as Dr. Mansi said, there may be even a pyosalpinx which can happen, as the fluid can no longer drain.
But madam, what I really
I'll finish with
don't
the last
understand.
line. I'll finish with the last
Yeah,
line.
yeah.
For this reason, if you're doing a clipping and you see a big hydrosalpinx, you can consider fenestrating the hydrosalpinx rather than removing also. That is also, yes, Ashish, please continue.
I just wanted to add to all of this, it is not the controversy. Ma'am, whenever you do a salpingectomy, I know the blood vessels are from the mesosalpinx and which will not cause that effect. But the thing is that whenever you just clip the tube, and what the ASRMC, these are the guidelines based on the vast experience. It is not mine and anyone else experience to talk about.
This is also a guideline. It is not from a small study.
Yeah. So it is better to see the hydrosalpinx effect rather than what is the nature of the hydrosalpinx. If it is a terminal huge hydrosalpinx, the fenestration will be helpful.
Yes.
If it is a mild hydrosalpinx, why to remove all the tube? So it is better to
And,
do just
and
a clipping.
sometimes it's very
Yeah.
difficult to, like, if it's a tubo-ovarian mass, it's happened of an abscess or something, it's very difficult to actually remove the tube alone. Most of the time, the ovarian tissue also may be stuck there. Sometimes they
True,
may
ma'am.
be difficult also.
Yes.
So, and I think Dr. Jay Mehta touched on this. Will salpingectomy reduce the ovarian reserve, Dr. Reshma?
No, not at all.
Not
No,
at all.
ma'am, if we really go near towards the tube, then definitely not,
It will
because
not reduce the
mesosalpingo
risk.
does not.
And you need not obsess about that mesosalpingus, ma'am. You can actually do a correct surgery and you will not reduce the ovarian reserve. And that's what the
Yes,
guideline
sure.
also says. There's no difference in the dose or duration of gonadotropins used or the peak estradiol levels when they did salpingectomy and then proceeded with the IVF procedure. And there was no difference in the number of oocytes retrieved or the embryo quality just because they did a salpingectomy. So that's also equally clear. And Dr. Adinath sir, like if it's an unilateral hydrosalpinx with infertility, then what? One tube is totally damaged, other looks okay. Then what will be? Will you change your method now?
Depends upon the size of hydrosalpinx. If
Yes,
it is
sir.
huge and distal part of this fallopian tube is also damaged very badly, then it is better to remove the
Even if it's a unilateral hydrosalpinx.
Yes.
Suppose other tube looks normal, will you go and clip that or take off that tube also? Just because you think there may be an hydrosalpinx there?
When it is damaged very badly.
No, if it looks normal, the other tube. I'm asking about the contralateral tube.
Other side too.
Other side, what will you do? Will you take off only that hydrosalpingal tube which is visible, or you will think about
I would
the other
like
tube
to
also?
remove the only damaged.
Only the damaged tube.
Yes, rather than the remove both.
Remove other, yes. So when you do a unilateral laparoscopic salpingectomy or an occlusion before a IVF procedure, they said it gives very good results because unilateral hydrosalpinx also contribute to lower pregnancy rates with IVF. It need not be bilateral. And there are several case reports of spontaneous pregnancy after a unilateral salpingectomy or a clipping of a unilateral hydrosalpinx. So you should go ahead with a procedure if the patient is manifesting with infertility and just got even a unilateral hydrosalpinx. And as Dr. Adinath said, if the other tube is fine, don't go and do anything, because even the other tube, if she's able to conceive spontaneously, you're going to give her a chance. So don't touch the other tube, even if it is patent or not patent. It should be patent. And that's from the Human Reproduction in 2003. Selected patients with unilateral hydrosalpinges and patent contralateral fallopian tube may exhibit actually an increased cycle fecundity after salpingectomy or a proximal tubal occlusion of the affected tube and conceive even without the need for an IVF. And what about, Dr. Kekin, what about ultrasound guided aspiration and sclerotherapy? Suppose she does not want a laparoscopy. She says, I read on Google and I want only an ultrasound guided aspiration.
No, ma'am.
What are your thoughts on that?
I would not recommend ultrasound guided
aspiration.
of the.
How
Yeah,
about
because
aspiration and
then-
sclerotherapy? Will you consider that sclerotherapy with aspiration?
No, ma'am. Surgery, ma'am. Nothing else.
Okay, good. You will convince her for a salpingectomy or an occlusion, right? So actually, intervention to decompress the hydrosalpinx by an ultrasound guided aspiration is superior to no intervention. But if you add sclerotherapy, it is actually a good option. But as Dr. Kekin said, salpingectomy is the gold standard to optimize the reproductive options in the management of hydrosalpinx before IVF. But if the patient is adamant and she wants ultrasound guided this thing, you have to do it along with the sclerotherapy. Do not do just an aspiration. It's not going to be useful at all. It's going to refill again. So this is a reference which I've taken. It's not my opinions. It is 2021 Practice Committee of the American Society for Reproductive Medicine on role of tubal surgery. We'll go on to the next patient, and this lady is 28 years old, has a 44-year-old husband. They've been married for 8 years and they've come with infertility. The fertility assessment is quite normal. Semen analysis fine. DNA fragmentation done fine. 2 HSG reports or tubal patency is there. Endoscopy done with hysteroscopy twice and a laparoscopy once. Multiple endocrine profiles done in various centers. Latest AMH was 3.2. She's 28 years old. Before considering for ART, they had 4 cycles of oral ovulogins for induction and some cycles of gonadotropin and IUI. So then they went for IVF. This is not my patient. This was sent to me. So this patient, they have put her on a long protocol with HMG 300, 9 oocytes retrieved, 7 embryos, 2 transferred, 5 frozen. It was a difficult ET. There was blood on the catheter tip. She did not conceive. The next was a frozen cycle where thaw cycle was done and 3 embryos were transferred. Now, before the transfer, they did a pre-ART hysteroscopy, which was normal. Now she had a biochemical pregnancy, and again, she didn't continue the pregnancy. So then they went for another IVF cycle, and this was an ANTAC protocol with REC FSH and REC HCG. 10 oocytes retrieved, 6 embryos, 3 transferred, 3 remaining. The luteal phase support was done with heparin now. Embryo transfer was done under GA, still negative. February, she's got actually 1 straw left now. So can I ask Dr. Ashish now, would you opt for a fresh stimulation or ET or use those embryos which are stored in another lab? With this new ART Act, I don't think it's, you cannot do it like that like earlier. You have to get the approval from the National Registry, right, Ashish?
Yes, ma'am. Yes, ma'am.
Suppose it's before this ART Act. Would you ask them for the new older embryos, or you would like to stimulate her again?
Madam, I can recollect the case history from 2017 till 2018. See, there are long agonist protocol also give a fair oocyte. The embryos are fair enough, and transfer the frozen. Then again they transfer frozen and again frozen. But I think the protocol doesn't make any difference in the formation of the oocyte as well as the formation
embryos,
of embryos. So what I feel here, the 2 things which are really bothering me is, first is a luteal phase support. They had given everything and still the beta HCG is negative in 2018. Secondly, beta HCG was positive and then dropped down. So it means there is a chemical pregnancy or maybe an implantation may happen in second cycle. Third thing is I may not be knowing here what is the endometrial preparation they had done, whether this FET has been done with the down regulation FET or maybe a natural FET or maybe a FET with using
which
modified.
FET you think will be better?
I think if all the histories has been taken into account, it is better for me now to try with the natural FET.
Natural cycle FET.
Yes, natural cycle.
And
secondly, yes, ma'am. And secondly, I really wish to.
So you will ask for those embryos and transfer. You will not go for a fresh stimulation.
No, ma'am. I will not go for fresh.
Those embryos look good enough. They don't. They have not mentioned anything about the quality of the
about the grading is not been mentioned. And secondly, whether they are transferred day 3 or day 5, that has been not been.
Which is preferable for you, day 3 or day 5?
Madam, if it is a thaw embryos or cryopreserved embryos, I will thaw it. Then I'll make the potential whether the embryos are growing till day 5, and I'll talk about the day 5 transfer here.
Suppose they are frozen day 5.
Day 5, then again it will be. There is a beautiful article. If you just day 5 embryos, you thaw it for 2 to 3 hours and then transfer.
Transfer. Okay. Anybody would like to agree or disagree with Ashish? He's going to transfer the embryos from the other center if the government is giving him. And he's going to go for a natural cycle FET, and it's going to be if it's day 3 embryos frozen, he's going to grow it for 2 days and go for a day 5 transfer. Any thoughts on that? Any change of idea?
Ma'am, I would also add a PGD on day 5 if the embryos go
PGD also. Okay. PGD.
Madam, I think we can also do an ERA because 2 times she has had failed
implantation.
Whether the implantation window is
so that is another controversial point. ERA is useful. New studies have said ERA is not useful.
ERA is not useful at all. In 2023, they are postulated all the things are. It is endometrial receptivity is not hold true. That ERA is backdated now.
What is your experience, Ashish, now? Like, what is it? Because these are all, nobody is going to put up a guideline again regarding ERA. But what is your experience?
Madam, can I just tell you the truth? What I believe in the endometrial scratch work for someone. Same thing, the ERA will work for someone, but it is not been the gold standard to be used.
Pratibha, what is your thought about ERA and endometrial scratching?
I think endometrial scratching, I would go more with endometrial scratching because I have seen many patients.
So whatever the guideline is saying, we are not the guideline. There's no guideline yet, but there are studies which say it's not useful at all. 2014 in ESHRE, they kept on talking about endometrial scratching, and now they are not talking. It's become a bad word now. Do you agree with that?
No, I still feel that in my practical experience, endometrial scratching still helps.
What about Dr. Mansi? Mansi?
No, ma'am. I do not believe in endometrial scratching.
Were you doing earlier and now you're
starting? No, I was never doing it.
I
was never convinced by it, and I was never doing it. If my endometrium is bad, if my
what is your age, Mansi? I'm sorry to ask. What is your age, Mansi?
Man,
That's why. Yeah.
I'm same age as Pratibha.
Okay, good.
Uh,
Okay,
Yes,
Reshma, what is your thought?
I'm
Endometrial
we are in our
scratching.
early 40s,
I
madam.
also won't go with the endometrial scratching and even with the ERA.
Okay.
Scratching I have never done, ma'am. And
ERA?
I'm also practicing since 2017-18.
No, ERA. The question only for
ERA
was
also,
Mansi because
no.
because I know that all of you are young.
Even ERA, ma'am, I won't go with it because, as sir said, even the new evidence also said it won't helpful.
No, I'm asking
that
because see, they are saying help. What we are seeing in research is they'll say no. Then after 5 days, 5 years, they'll say yes. Then they'll say maybe, and then again no, and then yes. That's a circle we are seeing. We have been practicing for 25 years, and we're seeing the circle which is going on and on. I'm asking your experience. Have you ever tried scratching, or have you ever tried ERA? You feel it's useful or not useful?
Scratching I have never, ma'am, but ERA, yes, we have done.
Yeah.
But
Was it useful for your patients?
No, ma'am.
useful
In
at
2
all.
patients it failed, so I
Okay.
won't go.
You are not used. Dr.
Adina,
Adina,
the ERA is the same thing, you know. It's like as Dr. Kare said, it may work, it may not work. You have to explain to the patient.
So what I'm asking
The
is
ideal
may work
success
and may
rate
not
remains
work.
the same.
No, are you doing then? May work or may not work for you.
I've
No, you
stopped doing now. I
Stop
did it
doing.
for a couple of my patients, and
Then
I
you
was
stop.
not very convinced with it.
Then
So,
you
but
stop.
as you know, as you are saying, it may have a breakthrough, and we may have some exact guidelines and protocols, and maybe then we can start incorporating it on a regular basis.
See, because
but right now I'm not doing
we
it.
always rely on Western literature. So, but we have got a big body of work here, and we always try to think that they are better. But sometimes you will see that ours is much better than how they are following at the end of it. Dr. Adinath, what is your thought on endometrial scratching and ERA?
I would like to advise her go for the endometrial scratching and PRP also.
You do endometrial scratching and PRP.
Yes.
Good. Dr. Kekin. I'm having a
Dr. Kekin has
controversy.
left. He has left.
Yes,
he had
left.
some
Okay.
emergency.
Okay. Monica, you have to come in now. Half the panelists have left, so you have to
Yes,
come.
ma'am.
So tell me now, ERA and endometrial scratching.
Ma'am, I believe in scratching.
I would like to add one thing.
Yes, sir.
If she undergone the laparoscopy and hysteroscopy, at that time, if she had not done the TB PCR testing, endometrial TB PCR testing, then I would like to repeat the hysteroscopy and testing for the TB PCR.
Okay. See, why I asked that age factor, because I am from Grand Medical College, Mumbai, and when the 90s, I did my post graduation. So that time,
PNC was done.
No, anybody we put a lab and we see small white things, the peritoneal, we'll put them on tuberculosis, AKT drugs. And then we used to do a DNC and curettage for everybody, anybody who comes to this thing. You'll be surprised to see many conceived, Mansi. So that endometrial scratching, that's why we are convinced, because we didn't have any modality.
I would prefer to do a hysteroscopy rather than doing endometrial scratching.
We have heard that.
If I'm not convinced
20
with
years
the
back, 20 years back, it was a treatment, random treatment.
We didn't have
do
any.
the DNC,
yes,
and patient will get the pregnancy.
Laparoscopy and DNC patient, most of the patients conceive. So I think endometrial scratching gives a more receptive area, and I think whatever micro polyps that are there are removed, and then there is a good bed which is there for the embryos to get implanted.
Absolutely.
Then might as well do a hysteroscopy. Now, if you are suspecting micropolyps, do a hysteroscopy. Hysteroscope itself acts as a little bit of disturbing the endometrium. The concept of endometrial scratching is to change, immunomodulate. There is a basis of immunomodulation of the endometrial lining and make it more receptive. So I'm not saying that you don't do it. I'm just saying that there would be different ways of endometrial scratching. Some people will do it on an OPD basis. Some people will take it into a OT and do it a proper DNC. Some people will just do a hysteroscopy. The idea is to just re-stimulate the endometrium.
See, the truth is coming out. Truth is coming out.
I'm scratching, I don't do. Hysteroscopy, I do.
Hysteroscopy and you do you take a biopsy, right? So you'll be scratching the endometrium.
If there is
Madam, can I add something?
So Ashish will give us a conclusion. Yes,
No,
Ashish.
I'm not going to give any. Ma'am, I just feel when I listen to all of this, see why we do a scratching or why we do a hysteroscopy. There is only one way for it. That you need to understand. There is called as a niche. The endometrial niche has to get disturbed, and then there is an inflammation, that is a controlled inflammation, what you call as. If there is an infection, definitely by hysteroscopy you will try to understand there are the infection, and you will treat, and then the hysteroscope per se itself cause also an inflammatory reaction. And in your older days of yours, madam, when you do a DNC and they conceive, the thought behind is also inflammation causes a newer generation of the endometrium. So that was the concept of that DNC. So it will hold true for everything.
So whatever we said, you said it in a very polished way. But the same conclusion. And what I'm saying is, you disturb the endometrium before you do an IVF, and you do it with whatever method, because we have seen that just a plain DNC, many patients conceive during PG days, and after that, when we started talking about research only, I think like we think too much now. Sometimes the simplest of the procedure sometimes may help. So this thing is on, like, still endometrial scratching. They did an RCT for that. And now they did another RCT and they said it's not useful. So doing for a small group of patients, I don't know how it will help, but suppose we put up our data together, I think we can tell the world it may or may not be helpful. That's what I wanted to say. Like ERA, and we have already, ERA, I think as Ashish said, we don't know which patients will benefit. I've had a few patients who conceived, who had recurrent implantation failure. After we did an ERA and we timed the transfer, we have had quite a few pregnancies. So I don't know whether it should be thrown into the bin or something like that. But suppose you don't have any other avenue to counsel the patient, probably you can do it and just tell the patient you can try it. We can't give them solid results. But when you don't have any other avenue, I think you can try. Anybody wants to disagree on that?
Aditya sir has joined. We can.
Pratibha, it is? Who said?
Yeah, ma'am, I totally agree with you. ERA may or may not be useful. So we cannot rely on it.
So what are the best practices for a difficult embryo transfer? That first cycle, they had a blood down the catheter tip. So what will you do to avoid a difficult transfer in the next cycle? Can I ask, I think, Dr. Adinath? Suppose she had a difficult transfer. He has gone for dinner. Is there?
First, we have to assess the position of uterus prior to the embryo transfer.
So you have to do, you'll do a mock transfer before. That's what you are saying. Yeah.
Mock transfer. Okay. Whether uterus is anteverted, retroverted.
Okay.
Then we have to see the UCL first with the help of uterine sound in the prior cycle.
Okay. Anything else you have tried in your practice for preventing a difficult transfer in subsequent cycles? No, I'm asking like what all you have tried to prevent a difficult transfer in subsequent cycles.
I'm telling that. So mock transfer.
One. Anything else?
To assess the uterocervical length.
Okay.
With the help of uterine sound.
Okay. And then.
Bladder.
Usually it gets corrected for you if you do a mock transfer and see how it's done, right? Yeah. Dr. Kekin is gone. Okay, Dr. Ashish, what will you do?
Madam, in difficult transfer, the first of all, they already done in a second transfer, they've done a hysteroscopy. If you recollect the case.
Yeah, they've done a hysteroscopy for the second
So the hysteroscopy, they will just know, because in a hysteroscopy, what happens, you just under vision, you do it. So whether the passage is deviated or the uterus cervical canal is stenosed, then hysteroscopy will be helpful. But if the angle or the uterine angle is different, the hysteroscopy pre-IVF or pre-embryo transfer may not be helpful here, because whenever you do a hysteroscopy, you will be under vision. So in embryo transfer, it is not under vision. So I think better to do a mock ET, or maybe when you are using a catheter, use a different catheters. Like we take a catheter which is a radiolucent. Like you can hold the catheter, can be visualized. Yeah.
Ecotip, yeah.
Yeah, ecotip.
Okay. And Mansi, Pratibha. Then I'll ask Mansi. Pratibha.
Yes, madam. I also.
Dr. Aditya has joined now. Dr. Aditya has joined. Okay, we'll ask you. You will give the conclusion for this question. So Pratibha.
Madam, yes, madam, I am also of the same opinion that what we should do is we can see how much is the bladder full. Sometimes the bladder is so full that because of that excessive bladder, even the cervix gets compressed, and so it becomes a difficult.
Okay, yeah. So you will actually do a mock transfer with the full bladder or half bladder and see which is working for her, and the same thing you will do in the next cycle for the transfer, right? That's what you mean. Yeah. Mansi.
Ma'am, I will not, little different protocol than this. What I do is if I have a difficult embryo transfer and patient has not conceived and she's come to me again with a menses, on day 3, day 5, under USG guided, I do under local serial dilatation.
Okay.
Till 4 mm. 4 mm the patients usually allow. And that gives me an idea of the direction of the cavity as well.
You do it under anesthesia or without anesthesia?
No, without anesthesia and the
Anesthesia.
OPD basis, most of the, how you do endometrial biopsy, something like that. So I do it without anesthesia, I explain to the patient, I give position, USG is in place.
Would you put misoprostol before the dilatation?
Yes, I do that also. But day 3, day 4, the os is usually open. I know exactly where the blood is coming from, and then I go try to go in that direction under USG guidance. And most of the time successfully I've been able to dilate them. And once they are dilated, then the transfer becomes a little easier.
Yes. So actually you will try dilating without anesthesia and then do the transfer. Suppose it's not getting dilated without anesthesia.
Then, madam, I would like to do a hysteroscopy.
Hysteroscopy and clear all the angle and all that. How is happening?
Yes.
Can I ask Dr. Reshma?
Yes, routinely I do pre-IVF hysteroscopy. So the internal os thing has already taken care of. And usually we do mock transfers with a full bladder.
Okay.
So that helps us.
Helps us. Okay. Dr. Adinath, sir? Oh, he said already. Okay. I'm sorry, sir. Dr. Aditya.
Yes. So sometimes, madam, using a rigid stilette for a previous difficult transfer has always helped negotiating the deviated cervical canal at times. You have to be gentle, and if you are, at least that rigid stilette will help you reach the endometrial cavity. And then your transfer should be easy after that, inserting the inner catheter.
Okay. So when they did a study of physicians' opinion on how to do strategize before IVF for a patient who's had a difficult transfer earlier, as Dr. Adinath said, most of them did a mock transfer to map out the embryo transfer so that they do it easier. Some did a dilatation before the start of stimulation, as Mansi did. Actually, some did a cervical dilatation at the time of egg retrieval if they thought it was difficult. Many, I think 9% only managed it hysteroscopically. Some scheduled the transfer under anesthesia, and some used a laminaria overnight, a relaxant medication, or a cervical suture. I don't know how the cervical suture was done, but that's what in that study they had said. And suppose you had a transfer, you're doing a transfer and it's difficult, you have to vary the amount of urine in the bladder, as one of you said. You can use a stillet, as Dr. Aditya said. You can use a hard catheter to at least introduce for the outer catheter. You can change the type of catheter, as one of you said, and you can actually use a relaxant and attempt again after a break if there's a difficult transfer during that time. I'm not saying before a transfer. And other strategies which they have tried was varying the patient position, sometimes tried a knee chest position. I don't know how easy it is. And some used a os finder for slight dilatation. But Mansi said before, but I think they were using it during the transfer. Pre-cycle laminaria and dilation hysteroscopy with or without misoprostol several days before transfer. Right? All of these strategies were tried. And what do you think is the most common cause of difficult transfer? Dr. Aditya?
Most of the times, madam, it is deviation of the uterocervical angle. And if that is corrected by simple measures like full bladder and easy negotiation, you know your path, most of the times you should be having a easy transfer.
Easy transfer. So as you said, acute flexion of the uterus may be a reason. Sometimes acute retroflexion may be a reason. A tortuous cervical canal, but as Mansi said, in a hysteroscope, you will know how the cervical canal is, so you can actually plan out your transfer. And sometimes they've said there are ridges of false tracks in the cervical canal, which can actually cause a difficult transfer. Yes, Mansi?
Ma'am, I just want to add one point. So, the angle between the uterocervical line can sometimes be corrected by holding onto the cervix and pulling it a little. Now, in embryo transfer IDE, we are not supposed to hold the cervix. But if you have the thin alleys, which is 2x1, I've got one 2x1 alleys, which I hold on to if it's difficult, hold on to the cervix, put the outer catheter, then release it.
Okay.
And then do the embryo transfer. So that also sometimes works.
How were the results? Result.
Yeah, at least I was able to do the embryo transfer. The results were as equal, around 40%.
Okay. So holding the anterior lip did not make a difference to the results at all.
It was a very, I have a special alleys made for that. I don't use a tenaculum, it tears. The bigger alleys is too broad. This is a 2x1 alleys with a blunt tip, and it does not cause any trauma. And then
Any
if
name
I,
for the Alice? Is it Mansi's modification or something?
no, it's there, it's available. You can just call it 2x1 Alice.
2x1 Alice. Because I remember in Dr. Kamini Rao's center, there was one clinician who usually used to always hold the anterior lip of the cervix, and she said it did not make a difference at all to the results. And she was not using that smaller one which you said. She
So
was
you
using the
release it
regular
before
one.
you actually put the embryo transfer. You put in the outer catheter and you release it.
Yeah, I was scared, but she always said that it didn't make any difference to the transfers actually. So endometrial scratching, we've already talked on OSEUM. I think we need not go through that again. Now to the other controversy. Somebody talked about PRP already. What is your opinion on the mononuclear cells, the strategy of peripheral blood mononuclear cells, platelet-rich plasma, and subcutaneous GCSF before a transfer? Can I start from Dr. Ashish?
Madam, here I will say two things which has been a multicentric study also in my little bit experience about the PRP. Nowadays, everyone do a PRP, madam. The first thing is need to understand there is variability of preparation of the PRPs. Some of us are doing a double spin, some of us are doing a single spin, some of us are doing at 1200 RPM, some of them are doing it 1800 RPM. Secondly, the PRP, whether you are just making the PRP, whether it is activated PRP by addition of the chemicals or maybe a cryoprotectants, like you may just do a little bit at a lower temperature and then you thaw it again. So that is called as a temperature activated PRP. What we do it in our center. Only the indications for PRP in this patient, particularly what we are discussing, is a recurrent implantation failures. We found that that if like the same as that of the ERA, that it may play a role. I will talk to the patient. The PRP is only one way if everything is normal. So why not to place the PRP in order to have two things, that that PRP causes a decrement in the interleukin levels and the inflammatory levels. So the embryo implantation will be on a higher side because she had given the history of pre-implantation. So 105 was beta.
So you are convinced with PRP. That's what.
A little bit, ma'am. If there is nothing
bit.
else is working, I think better to try it.
Okay. Pratibha, what do you use?
Madam, I feel that PRP may, if it is put in the subendothelial zone, it may help. So I think PRP should not be injected blindly. If it has to be done, it has to be hysteroscopic guided. And it has to be in the, it has to be hysteroscopic guided and in the subendothelial layer. Secondly, if we are dealing with thin endometrium, means when we are preparing her for FET, and if the endometrium is very thin, we can put subcutaneous GCSF.
If it's not a thin endometrium, if it's a normally growing endometrium, will you put PRP?
Then maybe not. It is not.
See, Ashish presented his paper in Bangalore, so we heard him talk there, and he had presented his results also. So what about your results with that subendothelial installation of PRP by hysteroscopy?
PRP only if I feel that the endometrium is thin.
How are your results? I'm asking. Did it work?
Results, yes. For my patients for whom I have put for thin endometrium, yes.
For thin endometrium, it works, not for a normally growing endometrium.
No. I have never tried it also, madam, for normal.
Mansi?
I don't use a lot of PRP, so my experience, and I don't think I should talk. I don't have much experience on that.
What do you use then? Nothing.
Thin endometrium?
Not thin endometrium. She is like everything fine, not implanting it. Will you try any of this?
Ma'am, this recurrent implantation failure is a whole lot of new topic.
We want to know your idea.
So, ma'am, as far as my personal experience goes, again, PRP works in some and doesn't work in some.
So you use PRP. You use PRP.
Not much. I've seen other people use it.
Don't use much.
No, I don't use it. What I have done in few of my patients with recurrent implantation failure is still again a lot of under research. I've sent them to Dr. Raut in Mumbai, and they've done the lymphocyte immunization therapy LIT, and that has worked for 3-4 of my patients of recurrent implantation failure.
So lymphocyte immunization therapy worked for your patients. Then.
Yes, yes, it really worked.
Okay, Reshma. I'm getting the controversy from
yes,
everybody. Everybody is using different.
For thin endometrium, I'll
no thin endometrium. This question is totally.
I'm just telling But for the
No, I
recurrent
want to know
implantation
what will
failure-
you use for this patient. Thin endometrium is a different story.
Okay, recurrent implantation failure. I also send patient first to the Dr. Raut as routinely, and then we do late.
Where are you
out
practicing?
Of that, last
Where-
year I sent 4
No, where are you
patients and 2
practicing?
patients conceived
No,
at
where are you-
Satara, madam. It is very small town,
Okay.
small town. So I have to send patient to Mumbai if I have to transfer the patient.
Ma-
So 4 patient we did lead and 2 patient conceived this year. One is now 6 weeks and one is around 11 weeks.
Okay.
So I'll go that rather than with the PRP.
So your
Because
friend is,
endometrium is
your friend is Pratibha or Mansi?
I'm meeting Reshma for the first time.
Okay.
And Pratibha is a common friend.
Pratibha and yeah.
I know Reshma also, I know Mansi also. Both of them are close friends to me.
Okay. Dr. Adinath will tell us like what he is using. Dr. Adinath? Is there? Mr. Khan?
Yes.
Sir, yes, sir.
Please tell me.
So what are you using, like any of these strategies for recurrent implantation failure for a normal endometrium patient, not a thin endometrium? Peripheral
recurrent
blood
implantation
mononucleosis,
failure?
lymphocyte immunization therapy, PRP, subcutaneous GCSF.
We are using the PRP.
PRP using, yeah.
Yes.
Okay. You're getting good results, sir?
Yes, yes, we are getting the good
Okay.
results.
So 2 PRPs and 2 lymphocyte immunization therapy.
But not using the lymphocyte immunization.
You are not in comfort convinced
Yes.
with that. Okay. Dr. Aditya?
We have used platelet-rich plasma, but I have got mixed results in the sense few were promising, but in many I have not got the expected outcome.
Outcomes.
So I
Ashish, you
still
want to,
feel it's in the
yeah. So you will try when there's no other way out, and then if she conceives, it's good. Otherwise, you have to go for something else then again, right?
And these strategies are still not standardized, still in the research setting.
So you have to give us the data of which works, no? So then we can put up the guideline. See, this worked, how many patients and all that. Ashish, what is your problem? No, what is your this thing opinion?
Then my problem is a genuine one, madam.
Yeah.
When you're talking about the lead therapy, may I ask like those who are using a lead therapy, the first is on what basis they are advising the patient for lead therapy. The first is like there is a embryo and the endometrium dialogue, what all of us are talking about. If you are using a lead therapy, what is the evidence of the which NK cells or which immunological modulations you will be doing it, and how it will be like it will take 3 months. If at all I know, it is there are the CD56 and 18, the cells that they are calculating.
Ashish, I think you should have a dialogue with the persons who are using LIT. We'll have a separate discussion.
We will have to call Dr. Raut.
Because they are sending him. So Dr. Raut against Dr. Ashish Kale will have a dialogue.
No.
We'll suggest to Monica. Monica, next you should call both of them.
Yeah.
Sure, ma'am.
Included in the panel here.
Okay, yeah, thank you. So actually, they are saying like different studies, different meta-analysis, different reviews. All of them, like all the panelists said, Ashish is totally with PRP. Dr. Adinath is with PRP. Aditya is like here, there. The group is going for PRP. The female group is going for LIT. So nobody is agreeing on anything, but you try something and something it works, you would say that it happened because of that. Many times it could have been a good embryo that time, it was not there before also. So they did PMBCs and they said it is good, gave a good clinical pregnancy rate and live birth rate, and that was in 2021, and this was a meta-analysis. PRP also, people are equally convinced, and they said when it's done 2 days prior to embryo transfer, it gave very good implantation rate, clinical pregnancy rate, and ongoing pregnancy rate. And we have heard Ashish talking about it in so many conferences, and there seems to be an element of truth there.
Then this paper was PRP was put intrauterine or subendothelial?
This was intrauterine.
It is intrauterine.
Intrauterine, not subendothelial.
And Dr. Kare also uses intrauterine.
Intrauterine. He will give you a lecture soon. So, and he will ask Dr. Raut to come and give on LIT, right? So then GCSF, which you have been using for so many years, and same thing. Some patients conceive, some don't conceive, but they said when you give it subcutaneously, it seems to have better results than the intrauterine infusion of GCSF. That's what one study recently just said. It works much better. So it's your choice. I leave it to the panelists. Thank you so much for a patient attendance, because I think we have overshot by almost like 15 minutes now. Thank you, Monica. Thank you, Prerna, and all my esteemed panelists, Dr. Ashish, Dr. Pratibha, Dr. Mansi, Dr. Reshma, Dr. Adinath, and Dr. Aditya. Thank you so much.
Thank you, madam. It's a
Thank you,
pleasure.
madam. It was a wonderful practical pointer.
Thank you, Pratibha, for giving me this opportunity.
Thank you. Thank you so much, sir.
Thank you,
so
Dr.
much, Adinath,
Pratibha.
sir. Thank you so much. Thank you so much for attending the panel and being so enthusiastic and answering all the questions, sir. I enjoyed really being a part and inviting all of y'all. And we have had really nice discussion. Good points came forth, and Sharmila Ivu madam also concluded them very well. She has put down the guidelines. She has put down what exactly needs to be done and what actually practically we are doing. She has also taken out that very well from us. So thank you, Sharmila madam, for conducting that very well. Monica, are you there?
Yes, I am there, Pratibha.
Yes. So I think we can conclude this webinar.
Sure. I would officially like to thank Dr. Chamila ma'am for accepting our invitation.
She
Dr.
always
Kalyan-
calls me at the last minute, and she
No,
says you.
ma'am, this time I called you 3 weeks back, ma'am.
So 3 days is a short period of time. I'm old. I need to sit and prepare.
Yes, ma'am.
Madam, you are always prepared, and you are our best backup. That is what Monica told me. So if anything is not there, Sharmila madam will always say yes. So
Parag asked me the same thing.
You.
He said, "Why are you again going to webinar?" I said, "I can't refuse Monica. She keeps on saying, please, madam." So I say okay to Monica.
Yeah, ma'am. Thank you for being so helpful.
Thank you, ma'am.
Thank you.
I would like to also thank Kalyan sir and Jay sir for being the faculties for this webinar. Dr. Kiran Kurtkoti sir, Dr. Sudha ma'am, and Dr. Virkar sir as chairpersons. I would like to also thank all the esteemed panelists and the delegates who have joined. And Dr. Prakash Trivedi sir, who have joined as a chief guest and blessing us. Last but not the least, Pratibha, thank you for coordinating this event, and thank you, Walter Bushnell, for giving us a technical support and academic support for the same. Ma'am, there was just one question in the chat box. We would first answer that and then we could end the webinar. It is, what are the guidelines that need to be followed for transfer of embryos from one city to another, ma'am?
You have to apply to the national registry, get their consent, and then only you can transfer. They have to accept that it can be transferred. Otherwise, it can't be done.
Okay, ma'am. Thank you so much, ma'am.
Thank you, esteemed panelists. Thank you for the opportunity for Walter Bushnell to get associated. Thank you all. Thank you, Chamila ma'am. Thank you all. Have a nice evening ahead.
Thank you, madam.
Thank you.
Thank you, Baldwin, madam. It's a pleasure having you here. Thank you.
Yes. Thank you, Ashish sir. Thank you so much for joining. Thank you, Adinath sir.
Thank you.
Thank you, Dr. Pratibha.
Yes. Thank you. Bye, Aditya.
So can we stop this now?
Yes.
Thank you, Pratibha ma'am. Thank you, Monica ma'am.
Thank you, Pratibha ma'am. Thank you, Rasma.
Thank you so much. Thank you so much.